Fine. Once again, very good evening, ma'am.
Good evening.
First of all, we would like to thank Bangalore Menopause Society for giving us the opportunity, ma'am. And also, we thank you for choosing our field to show some our brands, ma'am. Few slides are there. We'll just read out the brand names, ma'am, if you permit. Shall I, ma'am?
Yeah.
Am I audible to everyone? Yes.
Yes, Bharat, go ahead.
Okay, fine. Yeah. So, Dr. Shield Innovation
off your video
Science
because
with
off your
Excellence
video.
is now connecting digitally via Shield Connect, a digital platform to reach and explore. And Shield is a highly respected pharma company with a focus on science and innovation. Shield focusing on identifying cutting edge solutions. And we have tie-up with, sorry, is it fine now, ma'am?
Stop your video so we can hear you.
Then you can hear better.
Yeah, I think this is fine, right, ma'am?
Yeah,
Yes. Yeah.
Okay, can I continue?
Yes.
Please continue. What happened?
Bharat?
Yeah, why don't you try somebody else projecting the slides if at your end connectivity. Send it to Suchitra, she will do it.
He wants to talk about it too.
He can talk and Suchitra can show the slides, no?
Yeah.
That
True.
can be done, no, Jyotika? Yeah. Hello, Bhagya Lakshmi. Sorry, I was late in joining.
No, Shobha, only 2 minutes late. Very good.
Thank you, Jyotika.
Madam, there was some technical problem. Sorry, I couldn't able to connect.
We can
So
take
we
it
just,
in between. Bharat, we can take it
fine, not an issue, ma'am. So thank you once again for giving us the opportunity, ma'am. So,
Yeah, you can tell your
Mr. Nisha?
brands now. You can
Yes.
list out the brands. You can tell us. We are
Yes,
all
yes.
listening. Yeah.
Yes. Ma'am, as you all know that, Shield is conducting, we have created Shield Connected digital platform, and extensive during this pandemic period, we have extensively done webinars, and we got appreciation from all the reputed bodies like Hindustan Research Corporation and Health and Wellness Confederation of Indian Industry, especially for doing such activity, and it is also been appreciated by all the gynecologists. We also have digital platforms where customers also can connect through Facebook, Instagram, Twitter, WhatsApp, LinkedIn, and through YouTube also. Ma'am, we also have brands like AppCode. So AppCode Max, we have AppCode Software, which we have recently introduced. And also we have global brand like Estrogen for especially for menopause, and UTI flush we have for recurrent urinary tract infections, and Totalis we have, which is a specific strains of lactobacillus for vaginal dysbiosis cases. So these are our organic range of brands, madam. So thank you for giving us the opportunity, ma'am.
Yeah, thank you. Your brand Totalis has been actually one of the first as vaginal probiotic, and after
Yes,
that
yes,
many
ma'am.
other brands have come. Okay,
Yes,
so
yes.
thank you very much for the help, and I think we welcome on behalf of Bangalore Menopause Society. We welcome you all to this current updates in cervical cancer prevention.
Yes.
We are very fortunate today that we have very a person who has worked in this field for all 3 years and more, and she's still working in this field, Dr. Bhagyalakshmi Nayak, as our principal speaker, and it will be followed by a very interactive session conducted by Dr. Sundari, and we also have another highlight from Dr. Aarti Gupta as who is chairperson of the Club 35 Plus of the Indian Menopause Society. She'll be introducing the concept of Club 35 Plus to be started with Bangalore Menopause Society. So with that, I welcome you all, and I request Suchitra to give an alert in the WhatsApp group for more, members to join, and also in BSOG groups, so that our speaker gets an all-out attention. With that, I would like to introduce the chairpersons for today. If I can have the series. Yeah. President Dr. Sheila Mane.
Yeah, I think you can go ahead. Just mention my name. We'll go ahead. Next.
Sheila. I would just like to say that Dr. Sheila Mane is president currently of BMS. She has been past president of the BSOG, and also she has held significant posts at Foxy of vice president, and also the chairperson of Safe Motherhood Committee. Dr. Sheila does have a vision for anything that she takes up, and this year we thought that we must focus on preventive care more and more, and that is why today she was very keen that we should start the Club 35. The next chairperson is Dr. Jyotika A. Desai. Yeah, please, can I have her CV? Yeah, so welcome, Dr.
Shubha,
Jyotika.
same thing with me too. You can skip it.
I know. And Dr. Jyotika is also past president of the Bangalore Society and of former president of Bangalore Menopause Society as well. In fact, she is the founder president for the society when it got converted from chapter to society. Several awards, as you can see. A very, very prolific reader, and has done significant contribution in publication. And welcome.
You are not audible.
To chair the session. Yeah. Okay, Sundari. Now is it better?
It is better. It's better.
Yeah, thank you so much for joining us all today. I wish more people would join. I request the chairpersons to introduce the speaker and to take this forward. Thank you.
Thank you, Shubha. Sheila?
Can we have? Yes. So I welcome Dr. Bhagyalakshmi Nayak. She's a professor in Department of Gynecological Oncology in Cuttack, co-chair Oncology Committee of SAFOG, governing council member of ICOG, and she was a chairperson of Oncology Committee from 2018 to 2021. Vice President Agoy in India, Joint Secretary Agoy, Assistant Editor, Indian Journal of Gynae Oncology. Just a minute. Peer Reviewer, Indian Journal of Surgical Oncology, Journal of Obstetrics and Gynecology of India, that is Jogi, and BMC Cancer. And she is an executive member of East Zone ISCCP. So all of us, we know that Bhagyalakshmi is really passionate about this subject, and she is very much into oncology, and she has done a lot of work that all of us know. And even when she was a chairperson, all of us have seen her working very hard towards the same mission, that is elimination of cervical cancer. So on behalf of Bangalore Menopause Society and all the members of our society in Bangalore, I welcome you, Dr. Bhagyalakshmi, to give this talk.
Thank you, madam, so much for all those kind words. And I'm really thankful to Bangalore Menopause Society with all the stalwarts leading this organization. So I think it means so much for me to be a speaker in your society today. So thank you so much, Sheila madam and Jyotika and Dr. Shobha, Rani, and so many others for giving me this opportunity. So I think more of science, I think I will be talking about some emotional things which actually we all of us know, but we are missing out in our day-to-day practice. So hope my screen is visible, madam.
Yes, yeah.
Okay. So I bring you greetings from the land of Lord Jagannath. So today we will be speaking about optimizing services for cervical cancer prevention. So I think everyone should really start thinking actually why we have taken this subject. So why we are not yet able to optimize the services for cervical cancer prevention. So I think at the end of my talk, we'll understand actually what is the problem and where is the gap and how we would try to mend this gap. So let me just remind you that 25% of the global deaths due to cervical cancer occur in India, and 1 out of 4 women who died due to cervical cancer in the world is an Indian. And so I think human suffering due to cervical cancer in India is immense. So I think it goes beyond saying that we are all concerned about maternal mortality, but the figures have now outpassed that. So we have all worked together. So I think the capacity of gynecologists in India, I think we cannot really compare it with any other society, because we have an immense capacity. And with this capacity, I think we have brought down the rates of maternal mortality. So now the rates of deaths due to cervical cancer have now surpassed deaths due to maternal mortality. So we save our mothers from maternal mortality and then allow them to die of cervical cancer. I think that's not something that can be forgiven. So I think we have to all work together. So I start my presentation with a case. She is KD, 66 years, menopause 20 years, presented with uterovaginal prolapse, underwent a Wadmeyer's hysterectomy on June 12th, and reported to the concerned surgeon with a histopathology report showing squamous cell carcinoma of the cervix and vagina. On clinical evaluation, wart was healthy, so no adjuvant treatment was advised. And then she presented a few years later to us with bilateral inguinal lymphadenopathy with left ulcerated with bleeding PV for 1 year. And the aspiration cytology and scrape from the wart showed metastatic squamous cell carcinoma. And I think this is sheer negligence. So I think it's really not forgivable that a Wadmeyer's hysterectomy has been done for a patient, but the cervix has not been evaluated. So this is a sorry state of affair. And India today mentions that more women in India die from cervical cancer than in any other country. And rural women are at high risk of developing cervical cancer as compared to their urban counterparts. So they are a little privileged, but I then cannot say that urban people are having screening or whatever. So I think we all understand that India, it's a huge problem. We all agree that it is a huge problem because the females between 30 to 59 years, in 2020, there were around 250 million. And in 2050, it's growing to be around 325 million. And 80% every 5 years, we are going to increase. So we have a diverse epidemiology, we have other competing health problems, and more than that, we also have a huge high risk group. We have commercial sex workers, we have HIV women, and India has the third largest HIV epidemic in the world. So I think all this put together, the risk for cervical cancer is very high. And cervical cancer in India, the alarming facts are that 200 women die every day, 8 women die every year, and every 7 minutes a woman dies. So this cause need to be taken up by multiple stakeholders, and public health issue needs urgent attention and action. And this death is almost like an Airbus crashing, but then that makes a lot of news, but these deaths don't. So here we were very happy that in 2008 and 2018 and 2012, the rates were going down slowly and steadily. But unfortunately, the last Globocan data in 2020 has shown again an increase, maybe due to proper documentation or there may be some other reasons, but there has been a rise in the increase of the cervix cancer incidence as well as the cervix cancer deaths. So I think that should ring a bell. And more importantly, the rates of cervical cancer that are going to rise in the coming years is going to be more in countries where the human development indices are low. Especially the projections indicate that there will be nearly 30% and 50% increases in cervical cancer deaths by 2030 and 2040 respectively. And low and medium HDI countries, especially regions where the burden is already the highest, Africa and Asia will be the most affected. So I think we have to take it up as a challenge. And thus WHO urges all the nations to pace up their efforts. And so the WHO Director General, Dr. Tedros, whom we see on the TV for Corona, has declared that we can try to eliminate cervical cancer as a public health problem through intensified vaccination against HPV, screening and treatment. And for that, we have some set targets for 2030. The vision is a world without cervical cancer. The goal is below 4 cases of cervical cancer per 100,000. For that, we need to vaccinate 90% of girls by 15 years, 70% of women screened with an HPV test at 35 and 45 years of age, and all managed appropriately. So that's so important that we not only screen, but also treat them, and a 30% reduction in mortality from cervical cancer after they have been diagnosed. So I think it's a huge task, and 2030 is just around the corners. So this is the group that we will be talking about today, which is called Screen and Treat. So the preamble by which we start working from today is, we appreciate what our predecessors have already done, what we are supposed to do, what we are doing, and what better we can do. So we have a beautiful immunization program that we are running. The government has set up a universal immunization program. So we have a groundwork ready for vaccination, but it just has to be launched. So we are looking at our Serum Institute and others to give it at a very low cost so that it becomes available to all our girls. So we have a very efficient infrastructure for immunization. We have camps being done here and there in many places. So each one of us is doing at most of their own capacity. NGOs are doing, but we need some organized programs. And I was not able to collect some photographs of some Lifeline Express, which is train which goes to very remotest areas of the Northeast and many hilly regions, in which we have screened women on these trains. So that was a real good program which Dr. Shobha had really told me to add, but unfortunately I couldn't get hold of the pictures of those. So that is again a program which Foxy had supported. We are doing a project for the Northeast, because the Northeast has the highest incidence of cervical cancer in India. And these are all the programs that we have done, that training the postgraduates. So I think they need to be aware about what is the problem of cervical cancer, because infertility, laparoscopy, they really look so nice to all of them. I don't think cervical cancer is an important thing for them to do. So I think they need to be sensitized about the program right from the day one. And for the last 13 years, we have been celebrating a cervical cancer eradication day on March 11th of every year, in which we actually identify people who have worked hard for cervical cancer elimination, and that happens to be the birthday of Harald Zurhausen, and he is aware about this, that we have been doing it for the last 13 years. So just to take you through the history of cervical cancer, the first description of cervical cancer was found in 4000 BCE by the Greek physician Pericles Hippocrates. So that time actually they thought that it is never seen in the nuns, that cervical cancer is common among sex workers and among women whose husbands hired prostitutes on a regular basis. So hence cervical cancer was considered highly transmissible and thought to be a very, very infective disease. So that again holds good today, because still we know that it's caused by infection due to HPV. So transmitting agent, this HPV reported in 1976, German scientist Zurhausen identified human papillomavirus in cervical cancer and warts. In 1985, Nature paper published it and established a foundational work for the later discovery of HPV vaccine, and he was awarded the Nobel Prize for this this invention of his. So WHO or IARC now classifies HPV as carcinogens. A group of the high risk ones are class 1 carcinogens and the others are class 2 carcinogens. So just to have a look at the HPV life cycle in the cervix, whenever there is an abrasion or an injury to the cervical mucosa, the HPV enters, multiplies in the cervical epithelium, and most of the time is thrown out. But once they start persisting, so persistent viral infection leads to carcinogenesis, and in a minute we will see. So there are some cells which are there in the basement layer or in the basal layer, and these are the cells. Not all cells are prone to HPV infection persistence. So these are some of the cells which are called progenitor cells, and they get infected. When they get infected, so it helps the HPV to become persistent. And once this happens, so many types of HPV infection happen. So one is called a productive infection. In this productive infection, the changes that have happened have a tendency to go back, and the next is a transforming CIN, in which there's a very less chance of it going back. So we really don't have any methods to know whether it is a productive CIN or a transforming CIN. So we are again looking forward to some tests which will tell us whether it's a transforming lesion or a productive lesion. So if it is a productive CIN2, it usually clears in 18 months. It's a self-limited infection that leads to viral shedding. If it's a transforming lesion, there is deregulation expression of the E6, E7, leads to loss of differentiation and invasion of the basal membrane and progression to cancer, which may take up to maybe maximum of 30 years. So no detectable difference in cytological or histological criteria in these lesions at the time of detection by screening. So Syntec Plus kit is a very important test which is now gradually coming into the market, a combination of P16 plus Ki67, which can be applied on conventional or liquid-based cytology. No morphological interpretation. Cells with positive staining for both proteins exhibit. If brown, the cytoplasmic staining for P16, the red one is the nuclear staining indicating expression of Ki67. So these are the lesions. When you are in a doubt, will help you whether you need to treat these lesions or not. So to differentiate CIN2 between those that will progress and those which will not. So journey through prevention. Current status of screening, it's opportunistic. We have organized screening is very, very meager. We have diverse situations, and screening is more in urban than rural areas. So screening and prevention, the preventive advances, we have had routine PAP versus liquid-based, PAPNet, etc. Still, VIA, VILI, and VIAM still have a role to play. HPV DNA testing is now becoming more and more affordable and more accessible, and we have capacity and the vaccine. So I think we have so many things in our armamentarium to screen, and we just have to start screening. So he is George Papanicolaou, who started the PAP test in 1954. And this was first introduced in 1940s. And with introduction, the cervical screening was established in 1988, and the impact was that the rates of cervical cancer fell, and especially in Iceland, Finland, Sweden, and British Columbia, where the rates of cervical cancer really went down. But the cytology has a dismal sensitivity rate, false reassurance even in high-grade disease because the sensitivity is very poor, and you may lose the best opportunity of diagnosis because that could be the only time that the woman would come to you. So this, we had some advances in cytology, which were known as the liquid-based cytology, which is simpler, and we collect it in a vial and send it. And the added advantage of this is that we get a clearer picture, and we can keep it also for a HPV testing. So however, a cytology needs repeated test at regular interval and needs a wide coverage, which is not a very, very feasible test for a country like India, especially when we are doing it in a camp setting. So the visual methods called VILI, VIA or VIAM. So VIA is called acetic acid, and WHO recommended this in 2010. And as of now, the government of India guidelines still tells that VIA is the standard of prevention test for cervical cancer. So visual inspection with acetic acid is a technique for the detection of precancerous or cancerous lesions in the cervix. Application of dilute acetic acid on such lesions triggers whitening of these regions. So we have a report of negative or positive. So this is the operational framework guideline of the government of India, which tells that every woman from 30 to 65 years should have visual inspection with acetic acid once in 5 years and refer to the PHC for further evaluation and management of precancerous conditions, where gynecologist is trained by anyone, lady medical officer is available. So VIA is inexpensive, it's immediate available of the result. we can do the screen and treat, we can do a large number of women, and a rapid training of healthcare workers can be done. However, it has a lot of drawbacks because it is very, very subjective, has low specificity, and cannot be used in postmenopausal women. So quality assurance in this VIA is very, very important. So HPV DNA test was approved in 1999, and in 2015, FDA approved this as a high-risk HPV test as a primary screening tool for cervical cancer. So HPV, this is approved now for by WHO for women more than 30 years, and you can add a co-testing to that. However, the challenges are that it's not available and really cost intensive, but the opportunities are that it will give you a chance for self-sampling and can reach the last mile woman who is not able to come to your clinic. So, and a testing for high-risk HPV DNA has a high negative predictive value, and a high-risk HPV negative tells that the risk of CS cervix over 5 to 8 years is almost negligible. So, however, we have to, having said that, I have to remind all of you that globally the percentage of HPV negative cervical cancer is also around 7% to 11%. So that's again not a very small. So in spite of HPV negative test, we have to remember that there's also a group where HPV may be negative. So single visit, coming to just to remind all of you that having talked about screening is not going to save lives unless it is stacked with some kind of treatment. So a single visit approach is to be encouraged. Screen and treat approach with VIA, HPV or cytology. Colposcopy for a screen, triage and treat approach. Portable colposcopes are also now available and can go to the last mile facilities. Health workers can capture and transmit images. Incorporation of artificial intelligence. So I think WHO is banking too much on artificial intelligence for diagnosis in the because our diagnosis is the new challenge. So there are many algorithms for screen and treat strategies. We have our FOXY GCPR, which is available on the FOXY guideline on the FOXY website. And more recently, we have the WHO guideline in 2021, which says that WHO recommends using HPV DNA detection as the primary screening test rather than VIA or cytology. So I think in the near future, we have to move away from VIA to HPV testing because Corona has taught us so many things that we can use those machines which were used for Corona testing also. And the recommendation is strong, and WHO recommends using HPV DNA detection as a primary screening test rather than VIA or cytology, even in women with HIV. And number two is WHO suggests using an HPV DNA primary screening test either with triage or without triage. You may do some kind of triage with it or maybe without it. But in HIV positive women, you need to do a triage because the HPV positivity rate is very, very high. And in a screen and treat approach, again, WHO recommends that using HPV DNA detection as the primary screening test, WHO suggests treating women who test positive for HPV DNA among the general population of women. In a screen, triage and treat approach using HPV DNA detection as the primary screening test among the general population of women, WHO suggests using partial genotyping, colposcopy, VIA or cytology. You can do anything to triage, but even if you don't triage, you can directly go and treat a HPV positive woman. So similarly, in a screen, triage and treat approach in HPV DNA positive women with HIV, you can do a VIA, you can do a cytology, anything to triage it, but in HIV women, you need some kind of triage. So screen and treat, is that effective? Yes, a South African RCT conducted by WHO in which either a VIA positive or HPV positive was treated with immediate ablation, and the treated HPV arm showed a 77% reduction in CIN3 and the treated VIA arm showed a 38% reduction in CIN3 lesion. So I think it is very, very effective method. And treatment of women with positive test results with cryotherapy or thermal ablation in the same sitting was done. For low resource settings, cost, time constraints, access, everything can be taken care of if we follow a screen and treat approach in the same sitting. And the added advantage is that you can treat any kind of infection that the woman is also suffering from. So it can be ablative or excisional procedure. And the ablative procedure is to destroy the entire transformation zone up to a depth of 7 millimeters. It's based on the observation that CIN may exist up to 4 millimeters inside the gland crypts. A prerequisite is that the entire portion of the lesion and the transformation zone should be fully visible, and there should be no or minimal endocervical extension. Colposcopic biopsy must be taken from the most suspicious area. There should not be any suspicion of invasive cancer, and there are various types of ablative methods. The commonest which is followed is the cryotherapy, application of extreme cold to destroy the precancerous tissue, and the cryotherapy leads to cryonecrosis. Rapid freeze followed by a slow thaw is the most effective approach, but now a double freeze thaw cycle is more effective than a single cycle, and this is a method of choice even in low resource settings. Cure rates are appreciable. So it has many advantages and disadvantages. It is simple. It can be performed by trained and competent non-physicians. Electricity is not required and has very few complications. But the disadvantages are that tissue is not available for histopathology. There is less effective for treating CIN3 and not appropriate for endocervical lesions. And out of the other ablative methods that are available, radical diathermy, cold coagulation, cryopen, electrocautery, I think cold coagulation, otherwise known as the thermal ablation, which generates heat by passing electric current at a lower temperature of 100 to 120 degrees, lesser possibility of severe burn, and low cost and appropriate for low to middle level providers. And now this is available as a handheld battery operated thermal ablator and is easily available. You can carry it anywhere. You do not need electricity for this. It's available with rechargeable batteries. And there are also excisional procedures, provide tissue for comprehensive histological examination, microinvasive and glandular disease can be recognized, margin status can be assessed, and this also can be used as a see and treat policy. So LEAP is the most widely used excisional technique, utilizes high frequency, high voltage alternating current. Loops are available in various sizes and shapes. Loops are wider than the lesion. You choose the loop which has to be wider than the lesion, and the technique is again easy to learn, easy to teach, and easy to apply. So eliminating cervical cancer. So the million-dollar question is, can we deliver? So I think a word about elimination. What do we mean by elimination? It's the elimination is little different from control and eradication. In that, elimination of disease incidence reduced to zero in a defined geographical area of infection. It's the incidence of infection caused by a specific agent reduced to zero. But as a public health problem, achievement of clear and commonly agreed target definitions. And for cervical cancer, it is 4 per 100,000. If we reach that level, it is called elimination. And cervical cancer elimination, Australia is going to be the first country to announce elimination of cervical cancer because of its vaccination and screening strategy. So it is all about attitude, because the Australian Prime Minister and wife tied to pharma pushing mandatory vaccination after the Prime Minister's wife was detected with cervical cancer. So in India, it is different. When big shots get cancer, they go away to slow and country to get their treatment done. So again, it's all about attitude. So 90% girls fully vaccinated, and we need 70% of the women screened and 30% reduction in mortality. So if we work by this framework, then there is, if we only do intensive vaccination, it will take a long time. If we do very intensive screening and vaccination, then it is possible that the rates of cervical cancer will fall. And for elimination, again, we will be taking around 50 years. We start working today. So many innovations are coming into the market like a tsunami. So out of these, I think smart scope is one important thing, because of the VIA, which we use as a screen and treat method, is very, very subjective. So smart scope is a make in India project, which tells that you can use it, can be used by paramedical workers, or because it uses artificial intelligence, it can tell you whether a lesion is benign or suspicious. And this is the thermal ablation. I think these are the two things which are going to change the way cervical cancer is going ahead. So this is the smart scope, and this is a small instrument, uses a tablet. And here you can see some of the reports in which green, the report says that the lesion is green, that means it's safe and does not need further treatment. Amber means it has to be referred to a gynecologist, and red means it's suspicious, so needs some kind of treatment. So these are the reports that are generated by the machine itself, and so the subjectivity of the VIA is reduced by this. And this is the thermal ablator, which is a handheld method and is very, very simple to use. And I think anyone with little idea about the cervix, where it is, can usually use. So there are other methods also which are coming in, is the DISES, TrueScreen, and Z-Scan, which all use artificial intelligence and WHO is banking too much on that because of the human errors. So we have raw evidence again that inappropriately managed cases, that is again a concern in a country like India. Very often we come across cases, they are asked for further management immediately by some sensible surgeon, some abandon to get rid of her, no advice at all after surgery. So they come late, complicated cases. So women, unfortunately, the number is high, and the number coming in advanced stages is also very, very high. So I think it's the onus is on us. So when a surgeon, sometimes general surgeons also mishandle cases and send them off to other centers. And very rarely gynecologists helped by the surgeons do wrong surgeries, and that is again very, very depressing. So controversy, diagnosis, sometimes complacency in spite of knowing that it's a cervical cancer, they're operated, and we don't know about my competency. I should know I will be able to operate or not, and sometimes confidence I can do it. And the concept of oncology is sometimes has to be learned and cosmetic to do a NDVH. So that's again a fancy now. So diagnose properly before proceeding, look before you leap, do not treat if you are not confident, train and do, learn and earn, not earn and learn. First treatment is the best. Try to do with best of your knowledge and ability and passion. So this is appeal to all my younger colleagues. So otherwise this is what is going to happen if we do not screen a woman, see her and treat her. So, and this is a study which we have done. We have seen that many of the wrong treatments have been done by senior gynecologists, around 56%, juniors are less, and general surgeons assisted by gynecologists. So that's a very important thing, that wrong treatment being given to patients. So that's again a problem about cervical cancer. That's a malady in India today. So an expert is one who knows more and more about less and less. So we need to focus more about what we are doing. And maximum of this inappropriate treatments have happened at private hospitals and government hospitals, a little less. And in rural places, it is still less. So I think I will appeal to all of you that do not give away your touch, which is the speculum examination, to tech, which is the TV scan. So it's so easy when a woman comes to you with irregular examination to write on your prescription pad TV scan. So before sending her for a TV scan, please touch the patient, use the speculum examination. Do not lose on that. So I think revive the old touch. Let not tech replace the touch. So there is where we are faltering. So please go back to your speculum examination. Use your pap smears and learn colposcopy, which is also available. So consign cervical cancer to the history books. Is that possible? So it has two major problems. First, it requires skilled clinicians to conduct pelvic examinations, collect specimen for testing. Second, the considerable stigma, embarrassment, and shame associated with pelvic examination limits the acceptability of such screening programs among women. So I think we have two very, very important problems that we have to face. So an appropriate response to this eminently preventable cancer should be made an integral part of the women's health policy if India is to achieve universal health coverage as envisaged under the UN Sustainable Development Goals. So all of us here are sometimes representing our foxy body or our organization in policy meetings. So I think it's so important for us to place this in front of policymakers to make some kind of important policy changes. So I think it is possible. Elimination is feasible. Status quo is not an option, that the number of cases will increase dramatically due to population growth, demographic changes, and changes in behavior. And the near-term benefits, 1 lakh cervical cancer cases can be averted by 2030. 250,000 cervical cancer deaths can be prevented by 2030. Now is the time to act. With knowledge and innovative solutions, we can eliminate cervical cancer. So the capacity to prevent cervical cancer requires more than a high performance screening test and screening guidelines. So it's not about what the guidelines are there and the what screening test that we are using. There is something more than that. So it's our attitude which is going to work behind all this. So now it is in our hands So to give a smile to that woman. So I think we rise by lifting others. So if I'm happy tomorrow, if I've done something better, so I think every day we should improve on what I have done wrong yesterday and do something better for our women in the coming tomorrow. So, and the very, very important thing is that if I start walking alone, I can go fast, but I cannot go far. So I think it's so important. I request all of you to come together. We can, we have to go far. So we have to all go together. So friends, please join hands in this very, very important fight against cervical cancer. And I think sky is the limit. So we have to all work together, start from today. So thank you very much, Bangalore Menopause Society, for giving this opportunity to me to share my heart, my thoughts about cervical cancer elimination.
Yes,
Thank you,
Dr.
Dr.
Jyoti.
Bhagyalakshmi.
Dr. Jyotika, would you
Yeah.
like to? Yeah.
Thank you, Dr. Bhagyalakshmi. It was, I think, Bangalore Menopause Society is honored to have had you as a speaker today. You gave an excellent presentation on how, if we join hands, like Sati Hath Badhana, na? So that is the way we all have to come up and try to prevent cancer, cervical cancer. In your talk, you had some very important take-home messages, which I'm sorry to say I wasn't aware of. For example, IARC classifying Hpv high-risk types as class 1 and class 2 carcinogens. Then again, CIN being productive type and transformative type, though the difference in HP is not much. And I would like to get a little more information about the Syntec plus kit, so that we can find out where it is available and what is the cost, and whether by taking the LBC with that kit itself, we can do the Syntec Plus, or it needs some more addition to it. And apart from this, the other thought of Hpv negative cancers in almost 7 to 11%. So that shows that in spite of vaccination, we can still have cancers. That is something which we need to think about. And the best, of course, was touch is more important than tech. Thank you very much for your excellent talk once again. We want to know more about the Syntec Plus kit, Dr. Bhagyalakshmi.
And also about the smart scope.
Yeah. After this, about the smart probe, and again about the thermal ablation kit too.
Yes, madam. So first talking about the Syntec Plus. So I think that's a very simple test, especially when we have ambiguity whether to treat or not to treat. So CIN1 is a different lesion, CIN3 is a totally different lesion. So when we have a diagnosis of a CIN2, especially in young women, whether to treat or not to treat, whether so that's the test when we can apply it on those cytology smears only. So that's a P16 and Ki67 marker. That's a proliferative marker. So if they are positive, so we understand that they are very actively dividing cells. So they need some kind of treatment. So that's a simple test, I think. The additional cost may be 1,000 rupees on the cytology, but I think the pathologist has to do the test, and the laboratory needs to be equipped with that. It's called a Syntec test.
Thank you so much. And what about the cost of the smart scope?
How much does it cost? I wanted to know from Bhavya. How much does it cost? Yeah.
Syntec around 1,000 rupees extra on the LBC.
But where is it available?
What we need to do, Sheila?
I'll just have to get back to you. But as I know, I think Metropolis is doing this test and Dr. Lal's. So these are the two which are doing it privately. But in our government setup, we have it. But
what is the cost of the smart scope?
Yeah, the smart scope is around 2 lakh rupees. That comes with the tablet, and it comes with a small colposcope like thing, which has to be inserted into the vaginal canal after applying acetic acid, and it captures all the images and stores them, and you can and they're kept in the server, and the person who is doing it can share it with the consultant to clarify whether the image is really something to be concerned about. And more than that, it gives them the
Not
color
visible.
of the, whether it's green means it's innocuous. If it's amber, then the paramedical worker
Suspicious.
needs to refer the patient, or if it's red, she needs some kind of treatment. So that's a sorry, add on to VIA.
Okay, do you have the facility? Can I ask Jyoti 1 minute?
Yeah, please.
Yeah. Is that now the facility is available to differentiate between the HPV associated and HPV non-associated? That P16 immunostaining facility is available?
Yeah, I think
Yeah. It's
Yeah.
available. It is done for many other cancers also, Sheila. So
Okay.
now it has been applied for cervical cancer, especially to distinguish CIN2. Now we don't have histopathologically CIN2 and 3 HSIL it is comes as. When it comes, we have to know whether it is HSIL, CIN2 or 3. To differentiate that, to differentiate the treatment, the P16 and the Ki67 is used. That is used for many other cancers also. So Anand lab and all these labs, Ravi labs, all these people have got that staining.
Yeah, the thing is what material is subjected for the testing.
This
That
is the
what
same
we-
pap smear material.
The same
Cervical
pap.
smear only. The cells are
But
subjected.
then you have to repeat the test, isn't it? You have to repeat the
the
test.
same slide, on the
On
same
same
slide.
slide they can add.
Shubham,
On the
on
same
the-
slide, they will add the
So
reagent.
once you do and they carry it forward, if they find moderate and severe HIN, they will carry it forward. They will do it
Shubha,
automatically.
it is with the LBC specimen. They can
Yes.
do it with that.
Yeah.
So once we
No,
send,
what I
it comes-
want to
the
say,
whole
when
report
they are,
comes back.
no, my doubt was when they are trying to test for HPV, okay. If it is HPV associated, or it could be not associated. If it is not associated, then they have to do every time. Do they have to do that P16 assay? No.
No, it is not to
Whether-
differentiate.
Sheila, you'll come to know only when she has a cancer
Yeah.
and you check for HPV and it is not there.
No,
Then you
it's
treat
not-
the cancer and you treat the cancer, that's all.
Yeah.
Bhagya, can I?
Yes,
Bhagya, with
yes.
your Bhagyalakshmi, with your permission. I
Yes,
think-
madam.
No, that's not the concept, Jyotika. This
Yeah.
is to say, see, there is only, right now, there's a very narrow indication is very minimum for this. See, one lady comes and she has got CIN2, she's very young. She'll ask you, if I leave it, will it become cancer, doctor? Because CIN2, 50% of them regress.
Regress.
You only have to follow them up. Okay. But this lady is anxious. She wants to know whether it will progress to cancer because she wants to have a child yet. Then you apply P16 and Ki67. That will tell you which cancers will, which CIN will progress to cancer, which one will not progress. Because the dual expression of these two proteins will not happen in normal cells. When even a single cell expresses this dual protein, one is only nuclear protein, that is P16, but Ki61 is present both in cytoplasm and the nucleus of the cell. So when both of them are present, as she showed beautifully color difference between brown and red.
Brown and
That
red.
means both
Yes.
are present. These cells are disorganized cells and they are going to become cancerous. So
Sundari,
that is an indication you get it. Okay. That
Sundari,
means
the
you can
question.
tell this girl, yes, in future you are going to get a cancer.
Yeah, so
Sundari,
Sundari,
the question
what I-
was,
Hmm.
like I had a patient who had cervical cancer,
Hmm.
but her HPV was negative.
That's
Okay.
what.
Iris was negative. For
Hmm.
such patients, the only treatment will be to treat the cancer. Because there's
Even
nothing else.
HPV positive also, if it is a cancer, treat the
You
cancer.
have to treat it. That's
See,
all.
after CIN3 or HSIL, you don't bother about HPV positive or negative. Suppose your pap smear is HSIL, you are not going to bother
Already
about
there.
whether it is HPV positive or negative there. That will come only for the further management of it.
But they
follow.
say that
But you go colposcopy
HPV
and do biopsy.
But Sundari, the
HPV
current guidelines by WHO is do only HPV testing.
Yes, ma, that is primary test if you do.
Yeah,
I'm telling-
primary.
See, primary test if you do.
Because
you
as
get
a
it.
We are
screening,
doing it
that is
now.
Yeah, we'll
Yeah.
discuss all that in the case discussions. No?
Okay.
Yeah, we'll
We
do
have
Okay,
case
fine.
discussions
Fine,
all
Fine,
doubt
we'll have it in the,
the
we'll have it
discussions.
there.
Yeah, Sundari,
Yes,
as a
ma'am.
further to what you were telling, the
Hmm.
doubt which I had from the very beginning, we send your lady LBC, it comes as moderate dysplasia, right?
Hmm.
And she is asking you that question, right?
Hmm.
So we inform the lab to further to perform the test.
Yes.
That's
You
all.
asked
No,
you asked this biomarker. You asked the biomarker then.
send another sample, right? On the same sample.
No. The same sample, it can be done.
That's what I wanted to know. Only she has to go and pay the extra cost. So, Sheila, shall we move forward now,
Yes.
or what shall we do?
No,
some
I
more
think we
questions.
should. If
Yeah,
there are chat box, just check any questions.
Yeah.
I had only asked one.
Yeah, I know.
One question was there that the thermoregulator, how effective it is, and have you had any experience of follow-up of women treated in this way, like with the thermoregulator, with cryo? I'm very interested to know, Bhagya, follow-up of women who have been treated with cryo and thermoregulator.
Yes, thermal ablation is
And these two are not, they are ablative procedures.
yes. About these two things, I think cryo is a little messy thing. We need a cylinder filled with gas, and once that's finished, so and carrying it is also difficult. And the biggest problem is that there's a lot of watery discharge for these women. And thermal ablation is basically very simple device, small. It's we can carry it in a small suitcase, and when we touch it on the cervix, actually it takes hardly 20 seconds, 25 seconds. It's just like boiling of egg. So the cervix, that portion becomes coagulates, the protein on the cervix coagulates, and it looks whitish. And the post-operative period, and it's almost painless. The post-operative period is also, I think, minimal. We don't need to give her any antibiotics. Only whatever I tell her is about sexual abstinence, and that's it. And when she comes back after 1.5 months for checkup, most of the time it will show a little congestion, but I think by 6 months everything is healed completely. And thermal ablation is the treatment of choice by WHO. Also, it has been recommended now. IARC also recommends thermal ablation.
Long-term follow-up of these women.
Yeah. I think many studies have already been done in South Africa, Zambia, and in India also. I think it was in which place I'm forgetting. Long-term studies have already been done, and thermal ablation has proved beyond doubt that it's as good as cryo and LEAP also.
What is the cost of the thermal ablator?
That's again 2 lakh rupees.
2 lakhs, both.
And 2 lakh, and it has no recurring cost at all. They are rechargeable batteries, and it comes with those probes. You can choose 2 or 3 or 4, how many you want. And I think that's very simple.
So, in other words, the follow-up in terms of patient symptoms is better for thermal than for cryo.
It's
right?
much better, because cryo has a lot of watery discharge for 2 to 3 months.
Very
The cost
clear.
difference
We can buy
makes
this,
the-
no, Sheila? Sheila, we can buy this for the society, BMS, and do this cervical cancer screening and
I think the vendor is.
I think we have to really look forward for that and see to it that we really,
Smart scope we can buy, Sheila.
yeah,
Okay.
we
And then
can
do the
buy and
tabs.
start screening.
okay,
and
okay, yeah.
We can discuss it later in the famous
Yes.
meetings.
There is a question. No, one more question, Dr. Bhagyalakshmi. LBC moderate dysplasia with HPV negative, do we need to do ablation?
Yes. Okay. Yes, madam. You have to. The next thing, technology is technology, but you have to look at the cervix once. So if you think that you need to treat, I think you need to treat. If it is CIN2, CIN1, maybe I will not treat. CIN3 has to be treated, but CIN2, whether it's HPV negative, but I think I will treat looking at her age. If
Even
I think this is the case.
HPV unassociated also, right?
yes.
Sheila,
And
this is
one diagram you showed, Bhagyalakshmi, that where the HPV enters and then it is out. So it could be the hit and run phenomenon also.
Already done its damage and gone.
No?
So,
Yes.
There is
Yeah.
a epigenetics, and then the genomic changes have happened and the virus is no more required.
Yes.
Right?
Yes.
And
Once
it
the
will further
carcinogenic
undergo
is started,
changes.
we
Yes,
don't need the
Jyotika.
HPV. Yes.
Yeah.
Sheila, for this case, P16 and Ki67 can be done
Can be done. That I agree. Yes.
for further management.
a young patient especially, it must be done so that you can, you can give
give
her
them
the
the
correct
chance.
local
Thank you.
treatment.
Yeah. Thank you, Dr. Bhagyalakshmi. I think we learned a
Thank you
lot.
so much.
Every day it's learning, and when the the expert talks about it, I think it really, I mean, you have covered everything, almost all the newer aspects, as well as all the doubts. Thank you very much, in spite of you being not well, being there and delivering this talk for our association.
Thank you, Dr.
Thank you, Sheila ma'am.
Thank you so
In
much.
case you all gave me permission, I would love to log out because I'm not well and have a program again in the evening.
Please,
Thanks
please,
so
no
much.
problem.
Thank you again. Thank you again.
Thanks a lot,
you.
Bhagilakshmi.
Thank you.
I just
Thank
wanted
you.
to know the
Bhagilakshmi, it was
from the
wonderful.
Shield people that whether they're recording, no, because some people might ask us for
It is
recording.
being
It
recorded.
is
Madam,
recorded.
record will be
It is
provided,
recorded.
ma'am.
Yeah, it's a
It
very
is recorded,
important
we will be
lecture
provided.
today, because I think
Yes,
it will
yes,
be
ma'am.
very useful. Yeah, thank you.
Yes, yes. Thank you,
And
ma'am.
next
Bhagyalakshmi,
time,
really, it was wonderful
next
session,
time,
ma'am.
yeah. Next time, Bhagyalakshmi, that lifeline thing must come to us. The lifeline.
Surely,
Lifeline
surely.
Express, huh?
Yes.
I was very, very impressed with her work when she was chairperson. So dedicated, and she kept a very low profile and she worked so much. So that was very inspiring for all of us. Thank you, Bhagya.
Thank you so
Thanks a
much.
lot. Okay, so can you introduce the next speaker, Dr. Aarti Gupta?
It's a pleasure to introduce Dr. Aarti Gupta. She is the chairperson of Club 35 Plus and Public Awareness Committee of the Indian Menopause Society, and she's also responsible for the publication of POIS in 2020. She's currently the president of the Agra OBG Society. Now, apart from all the awards and so many good points which are mentioned in the CV, I would like to mention that Dr. Aarti Gupta is also contesting for the post of Secretary General for IMS, a very enthusiastic member of IMS who works very hard. We can make out by the number of Club 35 activities which she has performed or which she has contributed to during her tenure now in the last 2 years. Club 35 was initially started by Dr. Jaideep Malhotra and Dr. Malinda Rahuja in 2016. And of course, POIS magazine was started much earlier by Dr. Sonia Malik. Presenting Aarti Gupta to you to tell us more about Club 35 Plus activities so that Bangalore Menopause Society also can follow suit in starting one in a society. Sheila, you want to add something?
Thank you, ma'am. Thank you so much for the introduction. Can you listen me, ma'am? My voice is clear?
Yeah, very clear.
Okay, ma'am. Thank you. So myself is Dr. Aarti Gupta from Agra. I am committee chairperson of Club 35 Plus and Public Awareness Program, as you all know. So I am here with you all because of Bangalore Menopause Society, and especially I am invited by Dr. Shobha Gudi, Dr. Sundari, and Dr. Sucheta. I am very much thankful to Dr. Sheila Mane. She is present president of Indian Bangalore Menopause Society. And I am thankful to Dr. Jyotika Desai also. She is past president of Bangalore Menopause Society. And I welcome to both of my speakers, Dr. Shubha Rama Rao and Dr. Bhagyalakshmi. No doubt Dr. Bhagyalakshmi lecture is excellent and it's very much informative to all of us. Now, I am really happy today because we are going to start Club 35 Plus at Bangalore. And for the concept of the Club 35 Plus, I will like to tell you, because all of us, we all practitioners are very busy, especially to do the public awareness program. Whenever any patient is coming to our chamber, and we are doing the counseling of each and every patient separately, we have to repeat the same things again and again, and we have to tell all the aspects of the disease, what are the pros, what are the pros, what are the cons, pros and cons of the disease. We have to explain to the patient. At times we are so busy, it's very difficult to explain all aspects of a disease to the patient. might be that may be a patient of the antenatal patient to whom we have to explain what is the second level scan, what is the third level scan, what is PPH, what is APH, what is PIH. So we have to explain each and everything according to the patient, to each and every patient. But similarly, if I will think about the menopausal patient, patient may have the AUV, patient may have the anemia, patient may have the hypertension, cancer cervix, cancer ovary. So many diseases are related to the menopause as well. What I feel, to do an independent counseling of each and every patient is very difficult. So we can do a counseling in a group. What we can do, suppose we are having 50 patients per day in our OPD. So what we can do, we can call the patient once in a week and we can do a counseling as a whole of all the antenatal patient, as a whole of all the menopausal patient. So this counseling will save our time and will give more benefit to the patients. Patients can know each and everything about the diseases. Now, what is the main problem? What I feel is this: even when the educated patient came to our chamber, he put on such type of the questions that at times we are irritated. What this patient is asking to us. This is a very common question about the ghee. So हर patient पूछेगा भाई घी खाना है कि नहीं खाना है. So there are lot many questions are like this which irritates us. But we have to tell our patient you are not supposed to take or what you are supposed to do. So concept of the Club 35 came with the counseling of a group. So what we usually do is we make a group. So group, how we can form a group, it's very important. What we are supposed to do is we are having so many contacts in our phone number. So many are friends, our non-medical friends, our medical representatives, unki wife of the medical representative, our staff, relative of the staff. There are so many people and we are having so many contacts in our phone. What we are supposed to do is we will forward the link of our public awareness group, Club 35 group, which I have already created. You have to forward that link to our patients, to our friends, to our family friends, or whosoever in your contact to whom you want to educate. You can send that link to those patients, those people. They will join your group by that link. Even you are not supposed to add each and every person separately, just to forward the link. We are so many doctors. I think Bangalore Society is having more than 200 members. Exact number the Dr. Sheila will tell me, but there are so many members. Even the 20 members of the Bangalore Menopause Society, they forward the link to their groups and their relatives and friends join that group. So we can start the Club 35 group by that simple way. So what we are supposed to do, suppose when we have sent the link to the people, then those people, when they have joined, suppose there are 20 people or 30 people or 40 people who have joined our WhatsApp group, which we have made with the name of the Bangalore Club 35 Plus group. Suppose there are the 30 members, then what we are supposed to do? Then we have to send the small messages to these people for the awareness of the medical subject. So what is the advantage of this? We are sending the message, we as a doctor, sending the message to the public directly. And when public get anything from an educated person, like we doctors, so the public will attach to it, she will listen to it, and she will mean it. So the main problem is this, that there are so many myths in our society, which we as a doctor should remove from the society. We should tell them what is the truth, what are the myths. So these small things we can do by the Club 35 Plus. Suppose nowadays we are doing 2 programs from the center. One, we are doing Aap Puche Hum Bataye. This is some type of the program which we are doing twice a month. So what we used to do, we make a 5 question, 6 question series, which we will forward to your Club 35 group. This will be forwarded from the center, and your people from the group, your Club 35 plus members, are supposed to answer these questions. So who will answer first and the correct answer? So that fellow will get the her name and her society name in the poise. We will publish the name in the poise. We are used to do this in the past also, but now again we are doing. So the name and photograph will publish in the poise, and there will be the two folders. One of the both the आप पूछे हम बताएं के लिए दो folders बनेंगे क्योंकि we are doing 2 times in a month. The another thing which we are doing centrally is we are doing a public forum centrally. In the public forum, we used to make one of the society to be the partner of that program. Last time this program we are having with the Delhi, in which Dr. Sonia Malik, Dr. Maninder Ahuja, and one more doctor. They are the 3 doctors who gave their opinion. Third is Dr. Sharda Jain. All the 3 doctors gave their own experiences, how they will try to be happy, how they can indulge happiness in themselves. And that includes their own experiences. It's really a very good program and very informative also and very inspiring also. So in the next time, when we will do the program, we have to select a society. I think we can select the Bangalore society for that. If all of you are ready, if all of you are ready, so we can do the next program with the Bangalore society. So if we have the Club 35 plus member, if we are starting the Club 35 plus, so then we can do that program with the Bangalore society. And the most important thing is what? We are doing so many webinars, we are doing so academic things, we are doing national conferences, we are doing local conferences, but this is a program by which you can do something for your patients, something for your surroundings, something for your public. So I think this is a social service also. It's a part of the social service. You are increasing the awareness in the people who are not related to your profession, but you are increasing to the general public. Ultimately, we all of us are dealing with the general public. We are handling them. And the most important thing which I feel is this: there are so many of the medical legal cases. Always the medical legal cases are where when we are not very much approachable to our patient, when we are lacking somewhere in the conversation with our patient. If we are explaining each and every part to our patient, so then the incidence of the medical legal cases is less. If we are increasing the general knowledge of the patient as a whole, so it's very important that we can let them understand what are the limitations of a doctor, what a doctor can do and what is not in doctor's hand. So this is a thing which we all of us should do. And what we used to do the one lecture and one panel. Suppose we take a simple topic, suppose we can take the thyroid, we can take the AUV, we can take the menopausal symptoms like hot flushes, and so many things are there. We can take one topic and one panel discussion by which we can make our public aware of these diseases. The very छोटी myths हैं, जैसे कि suppose there is a patient जो कि thyroid की दवा ले रहा है और उसकी thyroid normal हो गया, वो क्या करता है, thyroid की medicine बंद कर देता है. So we have to tell these patients that you are not supposed to stop the thyroid medicine. You are supposed to take it for your whole life. Similarly for the diabetes, similarly for the hypertension. So these are the things which we should do with the Club 35 plus. And this concept came from the Dr. Jaideep, as you have already explained in 2016. It's based only on this, we should increase the awareness of our public and our society by giving our time. Hardly 1 hour in a month or 1 hour in this time is not much. We can take out so much of the time for the awareness of our public. I think Bangalore Menopause Society can understand my point. If there is any question, you can ask to me. I don't know, I am capable of telling you my concept clearly or not. If there is any question, you can ask to me. And at the last, Dr. Sheila, I can ask for my competition, for my contest, I can say a few words.
Yeah, please.
So now I will like to tell you one thing. I am contesting for the post of General Secretary of Indian Menopause Society, and I need your vote and support for that. If you feel I can do justice with the post. Thank you so much. And you can ask any question if you want to ask.
Thank you, Dr. Aarti. I think I must say that this pandemic has taught us many things, and it has become easier, at least now, to get connected to people. So earlier we had to do it physically only, even 35 plus also, we had to arrange the physical meetings, which was definitely not so easy. But now, as everybody is tech savvy and everybody has a smartphone, I know it will be definitely easy. And I still remember you telling us in Bangalore to start. So today we got the idea from you. Once again, we will get in touch with you, and we'll see to it that each consultant forms their own groups, because
No,
they
ma'am.
will have their own set of patients. Is that way, or we have
No,
a common
ma'am.
group? Huh.
No, ma'am, there should be one group of the whole Bangalore.
Okay.
And the faculties, as you are doing this meeting by calling the faculties, so you will do once in a month a meeting. And nowadays you can do on the WhatsApp. But when we are doing it in person, what, जैसे कि suppose जब हम in person करते हैं, तो हम लोगों को member क्या कह के बनाते हैं? We used to say कि we will do your annual checkup in the minimum possible rates of all the members of the Club 35 plus Agra Menopause Society. Suppose I am from the Agra, so I will do a complete health checkup of Agra Menopause Society plus all of my Club 35 plus members. And in this health checkup, what I used to do, I will do the CBC, we will do the blood sugar, thyroid, blood pressure. इसके बाद we will do the BMD, pap smear. इसके अलावा breast examination. And if the patient needed to, we also do the bone examination by the
BMD.
DEXA.
Yeah.
So all the tests which a patient need, and we also do the counseling as well. Suppose there is a patient, we will do the BMI also. Suppose there is a patient who is obese. Suppose there is a patient who is having PCOD. So we do the counseling as well. We do the, we aware them about the carcinoma cervix. You can go for the vaccination. So it's a whole program, including each and everything. And what we used to do when we are doing in person, we take the 1,000 rupees for the whole year for the membership of the
that's what I
Club
wanted
35
to know.
plus.
That what
And
is the
in
fees?
the 1,000 rupees, we are doing the 4 meetings. Every 3 months, we are doing 1 meeting. And in out of the, other than these 4 meetings, we are doing 1 health checkup.
Okay.
So this is our routine we used to do, because any meeting will not charge more than 250 rupees if we are doing the high tea time. So it is approximately, if we are doing a middle class hotel, so we can do it in 250 rupees per head. So this is our basic idea by which we are running the Club 35 plus for last, I think it's more than 5 years. I'm running this since, I think since 2016. So we are running in Agra, and at present Agra is having 7 Club 35 plus, ma'am. And every club is having more. There are the 2 clubs who are having more than 100 members. There are 2 clubs who are having 75 members. And there is a very good number in the clubs.
No, that's what I wanted to know. Why are you having this different clubs? I mean, like this.
Ma'am, I have done it area wise because the people don't want to come 8 kilometer distance to travel.
Okay.
So to start with, I am having the single club, but when I have more members, then I divided into the 4 are in the Agra, ma'am. 1 is in Dholpur, 1 is in Firozabad, and 1 is also nearby Agra. So as is tarah se we are having the 7 clubs in the Agra. Even at the periphery, we are having 1 in Firozabad also.
I think next BMS meeting, you all can plan for inauguration.
Yeah.
Okay,
so
ma'am.
today we have floated the concept. Thank you so much, Aarti Gupta ji. बहुत अच्छे से समझाया आपने. और this is a good concept because Sheila, see what she says makes sense. Initially, we begin with one central group, and later on, other people can take it up and make their own group.
Once they
Yeah,
become more confident.
as people
Also,
go on joining, you know, that's how we can, yeah.
we can do. Another
Good
thing is,
concept.
see, Aarti, what we were thinking is mainly this involves some lifestyle modification for women when
Yes,
they
when
attain.
we talk about the lifestyle modification also.
And,
Yes.
and a change in perception of how every day should be for them. They have to
Yes.
focus on their health. Otherwise, it doesn't happen. You know, they're all the time involved with the family only. So that is
Yes.
why I have involved few other people. Aarti, are you there? Aarti Prasad? Aarti Prasad?
Yeah, I was thinking of the other Aarti just now.
Yes.
Ah,
Yes.
I texted her. Hi, can you put on your video, Aarti?
Yes.
please?
Yes.
Yes.
So, 1 minute.
Yeah.
Yes. I'm
Thank
here.
you.
Hi.
Thank you. Thank you, Dr. Aarti Gupta. Actually, I just messaged Dr. Shobha. I said I had a totally different concept about the Club 35 that you're talking about. So what we really need to do is I'm a physiotherapist by profession. So I run group classes for the older age group, basically because I feel women, as Shobha said, do not take care of themselves. Women have this concept of that family is enough. If they take care, that's it. If they are fine, I'm fine. It doesn't work like that. So my main idea about this whole thing was that we should bring out a lot of lifestyle modifications, as Shobha suggested. And this was the topmost in my mind, because we see a lot of people who have osteoporosis, pains in the back, pain in all the joints. So that's what we were really looking at. This is what I wanted to. In fact, I just sent a message to Shobha that she's given a different concept altogether to us about how to integrate counseling with this kind of lifestyle modification.
Everything will be needed, Aarti, eventually. Health messages will be there, cancer prevention, diet, and also exercise. Everything will be needed.
Yes.
But I was looking upon parallel disciplines to form the, one of the important parts, because only clinicians cannot lead this. That's what I felt, that we need help.
It should be a sub thing, like, isn't it?
So we need everyone in this.
Yes. I think all of us have to work like a team, more importantly. Work like a team.
Form a team. So I just wanted
I think we need, Shobha, we need NGOs, those who are working for women. There are
We
certain
need
groups.
dietitians.
Yeah. So we can
endocrinologists.
contact them.
Oh, yes.
It will be easy to catch them then, So we will take Aarti's help, and Dr. Aarti already have a group, so we can in the beginning to see to it. But the thing is, we have to have an inauguration, if possible, call them for that, because they will have to nominal fees, ₹1,000, which we will have to tell them. So all those things, I think we will have to put it on a paper exactly what is 35 plus club before we put forth, because all are educated and they should know what is it exactly and how it is going to benefit them.
Absolutely.
In order the whole thing to be successful, the whole thing to be, it'll
मैम एक बात मैं बोलना चाहूंगी
हाँ
कि
जी.
अभी when we are doing on the WhatsApp group, so we should not talk about the fee.
Yes, agreed.
है ना? We can when we are running it and when they feel it's very good, so then we can, when we are doing in person, then we can charge the fee. And ma'am, I have done personally. When we go to the group, so at last you have a feeling of the celebrity. वो आपको इतना respect और इतना honor देते हैं कि आपको लगता है आप पता नहीं क्या हो गए. It's really good.
Yes. Sorry for interrupting, Shobha. My take on this whole thing is that the gynecologists, the physiotherapists, the dietitians, wagera, whoever is going to be on the team, really need to work hand in hand, even to see that the WhatsApp group is successful. The number of referrals should really increase, and then only things will really work.
They need to be committed.
Absolutely committed to this WhatsApp group right now.
We had a health mela in the MSC. You remember, Jyotika?
Yeah.
You remember?
Yes.
Very nice.
So when we do the first launch of, we will do something like that. Something where, they can come and get their checkup done, and then we can close to them. Right?
Yes, Shobha. showcase what all we can do for them.
So that can be an annual event for all the groups, and they can, go
I
on.
think that is better, Shobha, so that the message will also go. We can involve the media also, and make a lot of publicity about it, so that more and more people will join.
More and more people will join by themselves. We just need to have the group going, first group going. Once we make a success out of it, we are done.
See, Aarti, what we are looking forward is the contact with the other women's social groups like Mahila Samaj, like Lions Club, like Rotary Club, wherever women. So we should contact them and
we can go and give talks there.
Yeah, we can tap their needs and ask them to join. And also the middle class, as Aarti Gupta has very clearly said, all our patients' families should be informed. All our representatives' families should be informed. That is very good that she has told us how she has formed the first club. So all practitioners in BMS.
That's a good idea.
To float the idea of such a group, and we can take it forward.
Thank you. Yeah.
Thank you, Aarti.
And both of us have something in common. Both of us have something in common.
शोभा जी एक बात बोलनी है मेरे को. आप इनिशियली क्लब 35+ में अपनी सोसाइटी के 20 या 30 एक्टिव डॉक्टर्स को ऐड करिए. जो आपके 20 या 30 जो भी एक्टिव डॉक्टर्स हैं उनको ऐड करिए और उनसे कहिए कि वो अपने ग्रुप में, अपने ही फोन में जो सोशल ग्रुप्स हैं उसमें वो भेज दे लिंक. जो लिंक मैंने क्लब 35+ में क्रिएट की है, उसी लिंक से आपके पास 40 या 50 मेंबर तो इतने आराम से हो जाएंगे. जब वो 40-50 मेंबर हो जाएंगे, इन द मीन वाइल यू कैन टॉक टू द अदर ग्रुप्स जिसके बारे में आप बात कर रही हैं कि आप महिला समाज या जो भी बात कर रही हैं. क्योंकि टू स्टार्ट विद द महिला समाज में डिपेंडेंट रहेंगे, वहां जाएंगे, उनसे बात करेंगे, तो इट विल टेक टाइम. तो दिस बहुत ही छोटा तरीका है कि 20-25 लोगों को आप उसमें ऐड करिए ग्रुप में और उनसे कहिए कि वो अपने ग्रुप से, अपने फोन से वे मैसेज डाल दें, उसी से लोग ज्वाइन कर लेंगे.
बहुत समझदारी का आइडिया दिया आपने. बहुत समझदारी का आइडिया दिया.
Yeah, Shobha, you know why involving NGOs at an early stage is not a very good idea.
Absolutely.
It may not work.
Very good.
Aarti, do you have any message to give for your anything else, Dr. Aarti Gupta?
Yeah, you must specify which Aarti, Shobha.
I know, I'm sorry.
Both of them.
मैं मैसेज दे चुकी हूँ कि मैं जनरल सेक्रेटरी की पोस्ट के लिए खड़ी हुई हूँ, उसके लिए आपका सपोर्ट चाहिए.
Okay, yeah. Thank you very much.
Thank you, Aarti, and all the best for you.
Chairperson, I request you to conclude and then we can introduce Dr. Sundari. Thank you.
All the best, Dr. Aarti.
Yeah. Thank you, ma'am. Thank you so much.
Thank you for introducing the concept. So
Shobha, can I speak?
Sure, we'll take it forwards.
Hi, yes, Dr. Anuradha.
See what I am. No, video I'll put it on afterwards. What I request our society to do is kindly make a protocol and let us know exactly how we are going to go forward so that I can take it forward through IMA. Pan India.
We need your help, Anuradha.
For this.
I think you have a Karnataka women's wing, right?
Yeah.
Anuradha?
Yes. So Pan India, I'm in touch with all the women doctors. So we will take it forward. Only thing is I need a fixed protocol.
We'll work on it, Anuradha.
ಮೊದಲು ಬೆಂಗಳೂರು ಮಹಿಳೆಯರಿಗೆ ಉದ್ಧಾರ ಮಾಡೋಣ.
We'll go through Bangalore. Thank you.
The only sad thing is we don't touch the rural population here who need it the most.
Absolutely.
But that needs again further.
I agree with
It's not
Jyoti.
easy.
Okay, we'll brainstorm that, Jyoti. We'll see.
So if you make a protocol from each of our branches, whatever activity we do, we will follow the same protocol. For example, Dr. Sundari has been persistently telling me, kindly don't do too many camps in too many places. Stick to the same area and keep focusing. That way, kindly come out with some suggestions so that we can take it forward very well.
You'll
Thank
get
you.
some results also.
Yeah.
Yeah, other suggestion will come up, Anuradha, in the interactive session by Sundari. I will speak about another initiative which we can take. Please let us proceed. No, Dr. Sheila, Dr. Jyotika, I request you to wind up and.
Thank you, Shobha. This was a very interesting session. First, the talk by Dr. Bhagyalakshmi, which opened our eyes to a whole lot of new avenues to prevent cervical cancer. And secondly, the very inspiring talk by Dr. Aarti Gupta about Club 35 Plus and how we can go about it. So I thank the organizers. I thank Sheila and Shobha for allowing, again, Sheila and me to be the chairpersons for this very interactive session. Thank you so much.
Thank you once again, Dr. Bhagyalakshmi and Dr. Aarti, for being there today with Bangalore Menopause Society. Thank you. And thank you, Jyoti, being there.
We are thanking each other. Chalo.
Thank you.
Yeah, so now I think even more exciting, because I think Dr. Sundari has such a wealth of knowledge in cancer cervix and its treatment. So senior
Please
cancer.
skip this, Shobha. Enough people have seen this. Please skip it.
No, let me talk, man. I have not spoken about you for so long, Sundari. Let me
Hey,
have the
come on. No need, Shobha, please.
So I have known Sundari for my entire career. I started, we both started in the same institution. I joined a bit later than her at MS Ramaiah Medical College. Worked together for almost 4.5 years. Very, very dedicated. Dedication, thy name is Sundari. That is what I would say. And the very beginning itself, she had told me that I would like to focus on one thing and I would like to work towards it. She has succeeded to a very, I must say, a very great measure. I would scale it very high indeed, because today we know that she has made a difference to this field in prevention of cervical cancer, at least in the region of southern Karnataka. Her area of interest is also high-risk pregnancy, apart from preventive oncology, and she's a die-hard teacher, both undergraduate and postgraduate, and students love her for her teaching style. She was the founder president of KSC Agoy. Oh, I didn't know you were the founder president, Sundari. Congratulations. Yes. I thought Uma Devi was the founder president. So thank you for the information. 2011 to 2013. And Karnataka Cancer Society Vice President also, founder and president of an NGO, Mahati Trust. So if the trust is still working, Sundari, please let us also kind of, see whether it can help us in our work. And it works for cancer prevention and awareness amongst rural and urban women of Karnataka. So welcome, Dr. Sundari. Please start the interactive session. My role is only to assist you in this. And I will see to it that you can discuss all the cases with fluidity. Thank you so much.
Oh, what do we do? I thought you are doing it. No. Are you not doing it?
You have the slide deck.
Yeah, slides. Okay, I'll get the slides.
Please share the slide deck.
Yeah.
Madam, share and you can.
I'll share the slides.
I will not be doing the discussion. You will be doing. You are the expert.
So no, I thought no. I didn't know how it was. It will be taken. Okay, fine. I'll share it now.
Yeah. So we have those who responded to our call for interactive session. Of course, all are welcome to interact. So we will take up to 5 hand raises for each case, and then Dr. Sundari will discuss the case. Anything
I thought they will discuss and I will be answering them. It's not like that, Shobha?
Yeah, you start the slide, Sundari. Can you please?
And whatever way is no problem. We'll be learning, whichever way.
Correct.
Okay. This slide, can you see the slide?
No,
you have not shared, I think. Please share the screen.
Yeah, I have to share the slide. I think just wait for 1 minute. I'll rejoin. 1 minute.
Okay, no problem.
Yeah. No, I have to exit from here.
Where Shobha is, I think we heard about 35 plus club. So the members who are present today, I would like all of you to come forward and tell me who are interested. Okay. So there is already a WhatsApp group which is already there, which was formed by Aarti, Shobha. So you're muted.
I know that. Yeah.
So
whoever responds today, we can add to
yes, that's
group.
what I'm saying. We'll make it active, more active, and then we will start working for it. Okay. Subhashya Shigram. As early as possible, I think we should start.
ASAP.
I don't know. somehow we have not been able to do much for the society. So I think Shubhasri Shigram is also late. So that way, after the conference, we have not been able to really do much because
Of COVID.
yeah,
Because of
the
COVID.
webinar
So we can
frequency is
blame
so high.
everything on COVID, yeah.
Yes,
Tejavati,
you
your
are right.
program is
You will be
no,
right.
your program is pending, Tejavati. You were supposed to do. You let
Yeah,
it be
I have
from your
told.
side.
Yeah. I have told
Vegan
Dr.
should do on
Bhavna.
ovarian cancer.
So we have the video ready, the no case. I'll ask Dr. Bhavna.
Ah,
I
yeah.
think
So
maybe
that,
BMS can have one program every month.
that's
you
what.
share now?
Jyoti, आप भी
No, you
कुछ
can
plan
finish
कर लो
up.
ना, ज्योतिका. ज्योतिका, आपको भी एक करना है ना.
हाँ करेंगे ना, क्यों नहीं?
तो किया नहीं ना किसी ने अभी तक.
अरे भाई डेट नहीं दिया, कुछ नहीं दिया तो कैसा करते?
आप लोगों से हमने पूछा था डेट. सबका
ठीक
नाम
है,
डाला
आपसे
था ना.
करेंगे, आपसे करेंगे.
No,
Teja,
the
your date
problem
can go in
was
Feb.
Sheila Jnana Varsha, and then the next this AICOG. No, that's the reason I think we got diverted a little bit.
Teja,
the
do
thing
it
is
in
the
Feb,
webinar,
Teja.
the webinar frequencies are very high. So, you feel little awkward to go on doing
Yeah.
and how much people can take. So
Shobha,
that is why-
Shobha, are you saying that?
One per month.
No, Shobha has to do. She is a chairperson.
Shobha.
Yeah.
Yeah, we
Okay.
can see her
So-
screen.
Yes,
Yeah,
Sundari,
we can see.
Yeah. Please
Slideshow.
Share, Mama.
Slideshow. Madam, please make it slideshow.
Yeah, thank you. Where is Dr. Sundari? I'm not able to see. Suchitra, you are sharing. How is it going, Suchitra?
ಇಲ್ಲ ಮೇಡಮ್ ಶೇರ್ ಮಾಡ್ತೀನಿ.
ಮತ್ತೇನಾಯ್ತು
ಬಂದಿತ್ತಲ್ಲ ಮತ್ತೆ ಹೋಯ್ತು?
ಜಾಯಿನ್ ಮಾಡಕ್ ಆಗ್ತಾ ಇಲ್ವಾ? ಫೋನ್ ಮಾಡಿ ಸ್ವಲ್ಪ.
ಇದಾರೆ ಅಲ್ಲೇ ಇದಾರೆ.
ಇಲ್ಲ. Am I audible?
Yes,
Yeah, you're
yes.
audible.
Yeah, I'll share
Yes,
this.
madam, you're audible.
It may not be slideshow because there is this one. I'll just share it. I think people can see the slide. Can they see the slide?
Yes.
Yeah,
okay.
Madam,
Slideshow may not, it has happened for me, but you may not see the slideshow. Okay. Doesn't
Yeah.
matter. You please see the slide. First slide, I'll go first case. May know who is speaking about it, Shobha?
No, I have asked them to raise their hands and I will
Okay.
identify and call out. Yeah.
Okay, 60-year-old pap smear asks us. She has gone for executive checkup as usual, and then the pap smear says ask us. Immediately somebody asked her to go for a colposcopy. Colposcopy looks normal. Now, how do we manage her? It's very simple, straightforward, but here the problem, I want the consultant to speak about the problem, what we would have faced when we do colposcopy in her. She's
Yeah, Dr.
60 years.
Manpreet? Dr. Manpreet?
Yeah, ma'am. Sorry for my throat. I have a sore throat. For this lady, she's 60. She's ascus, and by colpo normal, I suppose that we are completely able to see the transformation zone. So in that case, I think I will counsel her that even though there is a small abnormality in the pap, I would like to redo it after 1 year. And in case after 1 year, the problem persists. If the problem persists, then I would like to go in for maybe co-testing with HPV, or in case the problem is resolved and it's negative, then we can resume the 3-yearly screening for her.
She's 60-year-old. Can I take Jyoti's response also, Sundari? Yeah, Dr. Jyoti.
Probably this is a low resource setting, and that's why we have done colposcopy for this ascus case. Normally in ascus case, accordingly, HPV triage is what is preferred for fine. Okay, but then now that we have done and colposcopy is normal, and we should also understand that she's coming to 60 years. As Dr. Manpreet said, we can do after 1 year, we can do either a co-testing if she can afford. I don't know whether this lady can afford because we could not do high HPV triaging for her. And then if co-testing is done, and we can, if it is negative, then we can, already she will reach the 65 years also. Very soon, that
Doctor,
for the next test.
Dr. Garima raised there. Dr. Garima has raised. Garima, please put on your video, please.
And the problem is, as she's attaining menopause, even the transformation zone can go in, can slowly, it will be receding inside also, that we should understand.
Madam, yes, I would like to, if possible, do an HPV triage on this patient at the first go itself, because somebody who's gone through an executive health checkup would be definitely worried and would not be wanting to sit on a ticking box. So if the HPV triage comes negative, but still a 60-year-old showing an ascus, HPV may not be the only cause. We will have to look at other reasons also. So instead of 1 year, I would probably call her back in 6 months for a repeat pap smear, even if the colposcopy is normal. And like Dr. Sundari was asking, yes, for a 60-year-old, doing a colposcopy may not be very easy because of having a tighter vagina. The relaxation may not be great. We may not be able to see the transformation zone clearly. So we will need to counsel her that we sometimes may not be fully able to do a colposcopy. It might be an inadequate colposcope when we post her in for a colposcopy.
Okay, I'll take Shubha and then Teja.
Yeah, I would also like to say that here she is a 60-year-old who has gone for an executive health checkup, and probably she's been having checkups in the past years also. So I'd like to go into her records and see how the pap smears, or if anything else was done, whether she had any, HPV testing done previously, because obviously at 60, she's going for a master health checkup. I would expect her to be educated and, being on follow-up for a long time. So as I agree with all the people that yes, she needs only observation, and you may repeat the smear after 1 year. But if she has, if there's a change from the last year, the previous smear, then I would definitely do a HPV testing here and advise her accordingly. Because if that HPV is negative, though we know that HPV is not the only cause, I would just follow her up if it is negative on a smear. Maybe not every year, but at least less than 3 years, I would like to see her.
Dr. Teja?
Yeah, my answer also will be almost same because the risk of developing going on to CIN3 is very, very small, maybe 0.5 at 1 year and 2.5 at 5 years. So my advice will be, my treatment will be observation and repeat HPV testing at 1 year.
Okay, Dr. Sundari, please. Yeah.
Yes, see, we have different opinions saying that almost like everybody says it has to be repeated. Please remember one thing, what I said is 60-year-old. What happens in 60-year-old with the pap smear? First thing we have to remember is, unless the cytologist is very, very good, this ascus will come in all postmenopausal women because it's an estrogen deficiency. The cells are read as dysplastic or abnormal cells. That's the first thing we have to remember when we are talking about ascus in an old 60-year-old woman. She's postmenopausal. So the estrogen deficiency will cause some sort of a reporting abnormality, rather I can say. The cells are not, unless the cytologist is very, very experienced, you can get every day, I see this, people will be sent for colposcopy. That's number one point we have to remember. Now, other thing is, I think somebody said it like transformation zone. It is very important. None of you asked me colposcopy normal means is the transformation zone is seen or not.
Exactly.
Yes, it's very important because in a postmenopausal woman, receding transformation zone is normal. Whether I'm able to see it or not is the question again there. Okay, because how much of transformation zone we will see? And even endocervical, it is squamous metaplasia would occur. It's very difficult in a postmenopausal woman to go for a really to say that the transformation zone is normal, number 2. Number 3, HPV Dna testing. At 60 years, all of us, we don't have such a good knowledge about at 60 years what will be HPV Dna testing in women and what type of HPV. It is not 16 and 18 and 60-year-old woman. There will be other strains of HPV will be positive. Now there's a big question. all these strains which we see in postmenopausal women, are they carcinogenic? Like 54. I have a woman 54 for the last 3 years. She is positive and persistently I just observe her. There are like that. Then 47, 48, there will be multiple HPVs will be positive. If it is not 16 and 18, we are not worried about it. So first thing what we could do is, in 60-year-old woman, if you don't see the transformation zone, give her a local estrogen for 2 weeks and then I will give a gap of 1 week and ask her to come back beautifully. You will see the transformation zone and you will say that if you are a good colposcopist, you do colposcopy and you say, yes, colposcopy is normal, I don't worry, you come back after 1 year. See, the ask us 6.9% it harbors CIN2, 2.6 CIN3, and 0.18% of cancer it can progress to. Okay, so that is it's almost like we say this is inflammatory also can be reported as ascus. Postmenopausal estrogen deficiency cells also can be reported as ascus. Though ascus is given now in a reproductive age, like say 25 to 60 or 55, yes, they say either you do triaging with the colposcope or you do HPV DNA or repeat the smear after 6 months. I will see if a woman falls into category, even if I take a reproductive age woman, ask us, I'll take them into category whether she comes into high risk category for the cervical cancer. If not, comfortably, I'll counsel her and say after 6 months, you come back and do one pap smear. But pap smear, cytologist must be good. That is important for us. Otherwise, false negative pap smears are very high in India. That's why our pap smears are not good for screening. Of course, all over the world, but more so in Bangalore. So if you have a good cytologist, repeat it after 6 months because it progresses after very, very long time and it won't go for a cancer cervix, no? Okay. So probably you can do pick up CIN2, CIN3 in your due course of following her up, you will pick up CIN2 sometime.
Why not
LBC? Better, Sundari? LBC is better, no? LBC?
Yeah. See, I'll tell you one thing, Shobha, LCB is better. In this case, may not, both maybe say LCB is better where, you know, when a reproductive age woman, they have a lot of discharge. So what does LCB is? LCB eliminates all this blood. If suppose you scrape and there's a bleeding, that blood it eliminates, mucus it eliminates, and it clarifies the cells and the distinction of the cells, spread of the cells will be equal. But if you take sensitivity and specificity, both are same for CIN2 and 3. Okay. But CIN1, we don't even consider ascus and CIN1 as a precancerous because now most of them will revert back to normal. So LCB, if it is there, yes, definitely it will be much better because the clearer picture of the cells, morphology of the cells a person could see. So the report will be better.
I wanted to ask you is, are there the types of ascus are also there, right?
Yes, there are two types. Next slide is that. Shall we go for the next?
Yeah, please go.
And one thing I want to tell
Madam, I had one query, madam.
Sure,
here, when we report in a 60-year-old, when I say colposcopy normal, it should be reported as unsatisfactory. That's one thing.
Inadequate.
Secondly, if
that's what I wanted one of you to comment on this. That's why I purposely put it as normal here. Otherwise, it's a very simple, straightforward. No, why I put is all these factors. I expected that you will bring out. Inadequate. Shiva, it is reported latest terminology is inadequate. Whenever the transformation zone is not seen, you say inadequate or transformation zone 3. 3 means it's completely inside, 2 is partially it is inside, but you could see 1 is entirely on the ectocervix.
And
but this said normal, no, madam. Colposcopy.
Yeah,
that's why we assumed that
I wanted you people to ask me that question. As a 60-year-old lady, madam, how can it be normal? Is she on hormones? If she is on hormone, your colposcopy is of no use. That question I thought you people will bring in. Anyway, sorry.
Madam, I did mention that when colposcopy normal means that TS
exactly. You said that. Happy thank you. Manpreet, you said that. Yes.
Sundari ma'am, I also told that in the follow-up period, because she is postmenopausal, the transformation can recede and become T2, T3 also.
Yeah. Yes. That's what, those are the points we have to remember when you deal with. Suppose if everything is normal, see, ascus is there now. you have done colposcopy, they have not done the HPV. She has come for colposcopy, you have done. It is inside the canal. Okay, now what will you do for her? The same, okay. You take it as you can't see this transformation zone. Anyway, you have put somebody asked for colposcopy and you have done it. HPV report is not there for you. What will you do with her now?
Have you gone to the next case?
No, the same case I'm asking them last word of it. What will you do, Jyoti or Teja?
Madam, I didn't. Please, can I get the question, ma'am? Again.
Same question, same question. Suppose it is Ascus is saying pap smear. She has not got HPV DNA test done because of the cost. She has been referred to colposcopy. She has come to you colposcopy. You have done, and you can't see the transformation zone now. And ectocervix is perfectly normal. Now what will you do for her?
We are unable to see the. We have to take the ECC, no, madam.
Yeah, ECC is a better option. Madam.
You can do ECC at the same instead of sending her off saying, and you can do ECC. Whenever there is a disparity between the two methods, confirmation has to be done by a biopsy.
Yeah.
Either it could be ECC.
Sorry, I just want you to tell. I want you to tell the correct way of doing an ECC.
Yeah, correct way of doing ECC is a small, you can have you can have endocervical speculums are available. You can put the speculum, if the os is a little okay, if it is not a very pinhole os, you can put the endocervical speculum and then open the os and see whether you could see the transformation zone. With my experience, what I tell you is the transformation zone, once it recedes inside, there will be a squamous metaplasia. That's why even endocervical growths, you get a squamous cell carcinoma in old people. Why? This is squamous metaplasia occurs there. So you won't be doing the glandular epithelium, you won't be seeing it. If you see the transformation zone, it looks normal, you can say all what they said after 6 months, after 1 year, she can come back. If you don't see the transformation zone in spite of it, Shobha, small curettes are available.
Madam, I learned something from you. Once when you were doing the ECC and nothing came, you did it, you put it like a smear on the slide and sent it.
Yeah. So
you can use the cyto brush.
For me, I have a very small curette which goes into menopausal endocervix. Okay. With that curette, you just curette only endocervical canal. If you can't do it, probably you take endocervical smear and again, no, endocervical smear, you could have done it when you are doing pap smear. So there is no point in doing it, but you must get some cells.
Yeah, I had one problem here, Sundari. Many times I have also done ECC. The problem is we don't really get tissue.
Correct.
Exactly. That time
always the practitioner thinks that, okay, curette means I should put it in formalin and send.
Yes.
But we don't get anything to put in formalin.
Yes,
so
when you don't get it, you are sure that pathology is not there, number one, because any pathological cells, loosely they come off. Even a cervical biopsy, when you take, easily if you could biopsy an abnormal area, that means it's definitely abnormal. You have to struggle to get a small piece of biopsy means that may be normal. That's one thing, Shobha. One more thing what we could do in such cases is give an estrogen to the patient, let the transformation zone come on to the ectocervix, wait for 1 week after stopping the estrogen so that the effect won't be seen again in the cells. Because again, the cells, you may see something different cytology. So wait for 1 week and then do a colposcope. You can see the whole transformation zone on the ectocervix. Then you can take a call on it. Definitely you will be able to say whether there's abnormality or not. If there is no abnormality, this is because of the estrogen deficiency. You are assuring the patient to ask her to come back after 1 year for a pap test.
Thank you very much.
Shobha, I just wanted to add one thing. If in a 60-year-old, if the transformation zone is very well seen, I would be rather worried for the estrogen source. Maybe she is obese or, so I look at the ovaries as to if there is something else from where she is getting her estrogens. I would definitely expect her to be obese.
Very pertinent to this one, Shubha. Very, very nice. In that cases, I go to the extent of telling the patient, be having a screening for your endometrium. I get the patients like this with a good transformation zone on the ectocervix at 60 to 63. I tell them, please get closely monitoring your endometrium. Very nice, Shubha.
Very good message.
Imaging is important. Do a TVS, look at the ovary, look at the endometrium, and do appropriate biopsies.
Yeah. Yeah. So then
We'll go to
if
the next. Is it
don't
okay?
get endocervical tissue, the same whatever material we get, as Jyoti also said, we can make a
Smear.
smear and
That's what
She'll
Sundari
go
madam
on to
was
the
doing. When we didn't get any material, she used to put it like a smear and send it.
Sundari
Shall
will
we-
go to the yeah.
Yeah, see this 50 years, menopause 2 years, pap smear says AACH. That means that was what Shobha was asking. Are these two things are there? This is AACH. Colposcopy transformation zone is not visualized on ectocervix. What next? 2 years of menopause.
Estrogen.
Tejavati?
Estrogen.
Teja? Manpreet?
Here, because the transformation zone is not visualized and the pap smear is H, the incidence of further progression chances are definitely high. So two things I just wanted to check if we could do an ECC for this and a diagnostic excisional one. No, that was my answer. If it was seen well, maybe observation and HPV testing at 1 year would have been my answer. Because it is H, she needs further evaluation, like, do an ECC and then take a call.
Yeah, Teja, thank you. Manpreet? Okay, Jyoti?
Here, unlike the contrary to the previous case, here Hpv triage is not the primary. We have to do the some diagnostic. We have to do the ECC also here. That is very important. And the thing is here, the transformation zone is not seen properly. We should think of some diagnostic excision procedure, and our age is also 50 years, no? Whether we can do a cone or something like that. We have to see.
Manpreet?
In case this patient is compliant to follow up and she can come back, I would like to put her on hormones and see whether next time I do a colpo. If not, then I would like to do an ECC and see what comes out of it and then decide for a diagnostic.
Dr.
Excisional.
How about
I think
any role for single visit approach here? No.
Okay. Shall I? Yeah. Shubha.
No, I agree that, we need to evaluate her a little further because it is ACH. So either you do an ECC, if not possible, then maybe a large loop excision biopsy and subject that to histopathological examination. Because here I'm not bothered about any of the, adverse effects of doing a biopsy or doing a cone. So I think that would be important to evaluate her at the first sitting and then subsequently follow her up on smears.
It will be important to see for transformation zone. That is also there. Sundari, please take it forward.
They're right. See, whenever there is a high-grade lesion, suspicion of high-grade lesion, there is first thing is all of them said there is no need going for a HPV DNA like in the previous case here. We don't need to go, but we have to confirm the diagnosis because it is saying that it's a high-grade lesion. So it can harbor either 2 or 3. If it is 3, definitely it's going to go for a malignancy. So we need to have a definite diagnosis. ECC can be done, yes, because its transformation zone is inside. ECC is the simplest thing you could do. You get the material for ECC, fine. If you don't get the material, as they said, LEAP can be done for it. And then we have to confirm the diagnosis that it is not a high-grade lesion. Here, the HPV...
LEAP, Sundari, when the transformation zone is not seen, how to do LEAP?
You have to go a little deeper so that you get the endocervical tissue also, no, Shubha? See, you go a little bit of, say like, usually we do 4-5 millimeters, you go a little more depth, 7 millimeters depth. If we go, we get the endocervical tissue also in that LEAP. Then we can submit it to the histopathology and make sure that there is no high-grade lesion in that. Because usually these high-grade lesions, pap smear false negativity will be very poor, less. So we must consider them as positive and then do everything. And follow-up will be test of cure will be for this HPV DNA we can do. And
yearly, madam, yearly?
Yeah, yearly. After 12 months, on any procedures you do like a LEAP or a cone, anything you do, follow-up will be done only after 12 months because the healing of the tissues will take time. If you do before that 1 month, after 2 months, you ask them to come again, you try to do a pap smear, you get the false positive results. So you allow it to heal for 1 year, then only you will do the testing. Pap
That one
HPV.
question I have, Sundari, here, one question I have about test of cure as HPV DNA. What is the rationale behind doing HPV DNA in her when already she had a lesion?
See, what happens is in the tissue, what you have taken out, you remove the HPV DNA also. If it is persisting in the remaining tissue, like even vaginal wall, when you do hysterectomies also for these people, vaginal wall, you take the smear for the HPV DNA because if the HPV DNA is persisting, then the vault recurrence is common. Because when you take out the tissue, the thing is that you are taking out, see, HPV DNA is local, no, Shobha? It is not like general in whole body. It is locally present. And that abnormal area, if you remove in that abnormal area, it is there. That means it is beyond that abnormal area you have excised. If still HPV DNA is persisting, means recurrence chances are pretty high. That's why we do HPV DNA test. That is more sensitive than your pap.
Okay.
She's menopause also, no, madam. Don't have to worry. She has finished her children.
Yeah, whether they are
you can go deeper and take the cone.
Yeah, what is required, we have to do it then. Yes.
As a high cone that we traditionally called
cone.
a high cone or a truncated cone, like a high cone, you can do a large excision by a loop.
No, Shubha, if you could see the endocervical speculum, your transformation zone inside, because she's only 50 and 2 years. It's not like a 60-year-old lady. If you could see and you could see the abnormality, you needn't have to go for a high cone.
Correct.
You can do a diagnostic small cone, you can do, Shubha.
Yes.
But you don't see the transformation zone, then you have to go for a high cone in her.
High cone. Okay. Yes, ma'am.
Okay, next, shall we go for the next? Yeah. Shobha, something you said?
No, we will go to the next slide.
Yeah, 48 years, routine pap smear LSIL, colposcopy done acetovite area biopsy, HPV report is CIN1. Now, tell me whether LSCL, whether colposcopy is the right thing which is done, and then histopathological report is CIN1 and how to manage her. Yes, Shobha, take it up. How much time we have? We have already 6 o'clock now. Shobha. Shobha,
hello.
Okay,
she's
who
gone.
will
She's muted.
I think 4 people have raised their hand.
Yeah, please. One after the other, you can take.
Madam, one large trial has been done, the ALTS trial, where so many 1,400 or 500 people were recruited, and it was shown that most of them were HPV positive in these patients. So doing a colposcopy for LSL is correct, what has been done. And it has shown acetovite areas, and you have biopsied the area and it has come as CIN1. There is 2 things I can think of. Either you can do a, yes ma'am. Yes, ma'am.
What should have been the sweet score when it comes as a CIN1?
Yeah.
If you put the sweet score in.
Exactly. I was about to come to that. I was about to come to that. It is anything less than 4. This is one opportunity, especially if you are doing in a camp or if you feel this patient is not coming, you have done the colposcopy and you can see the sweet scoring based on 5 parameters. And if the sweet scoring comes below 4, then you will think looking at the acetovite pattern, the staining and the vascular pattern, all those things where the points are given. Then if you can see that it is less than 4, and if you feel this patient is not coming also, you can even without the biopsy, you can even do the single visit approach. Then and there also you can do the cryo, I feel.
See and treat.
Yeah.
See and treat. Otherwise, you can follow them up yearly for 2 years.
Next, please. Next, who has it? Teja. Yes. Teja, Shubha, and Matri.
Yeah, Shubha, you say, but I think I had the same as what Jyoti said. If you have
actually, I also agree with Jyoti, that would be the right approach. One would be either you follow up or you see and treat. So once you have seen that, you use a cryo, that would be the best option. And if there are any, if you can't do the cryo properly, then of course you may have to do a lead. But then there is no need for that drastic approach now. Follow up is what is necessary.
Yeah.
So you don't need to treat her.
Ma'am.
That's what you will say.
Ma'am,
No, only in a mofussil area where if the cervix is not looking healthy, that is why I suppose colposcopy was done, because otherwise with LCIL, I don't think it was indicated in the first
Yes,
place.
definitely not indicated.
yeah, ma'am, I would like to call her.
But I thought
Yes,
for
Manpreet.
LCIL we need to do
Manpreet, yes.
colposcopy only because that
Manpreet,
study has
ma'am.
shown, no?
Yes, Manpreet.
So much.
Ma'am, when we get a diagnosis of CIN, then then it matters that what we have got on the PAP, whether it is LCIL or it is HCIL or unknown. We just get an ASCUS, ASCH. Now, because we've got an LCIL in the previous PAP report, I think I would like to follow her after 12 months. Now, in that 12 months, I might do a code testing if she's affordable. If HPV comes positive, or her report again comes as ASCUS or anything more than that, then I would like to go for a colposcopy. She's 48.
Yes.
If not, then I would like to follow her up for age-specific screening, like 3 yearly.
Yeah.
Correct.
That's it.
Colposcopy
Now,
is not
they say
indicated
that
in
now.
the first place.
Yes, somebody is telling something. Yes, please.
No, that's what
Jyoti was
colposcopy is
asking.
not indicated right away. You can just follow her up. But if she's really affordable, then she can do HPV co-testing, and all our testing will be deferred to 5 years if she is negative.
Okay.
Madam,
Now the latest
Madam.
recommendation is for
I have
LSIL
a
colposcopy is
query
recommended.
Because of the trial, that study showed more than 80% has HPV positive.
But
So they said
generally,
you
I
have
think
to do
that's what
immediately.
even my doubt was.
Especially
Generally,
LCIL.
Yeah,
Shobha,
LSIL,
yes.
we don't advise colposcopy. Madam,
Yes, Shobha.
Yeah.
Sundari madam.
My doubt is here. Yes,
I want to ask Sundari madam whether colposcopy, what is this controversy is going on, madam, amidst us, whether what we have done colposcopy is correct or not?
Yes, now LSIL colposcopy is recommended by both WHO and FOXI guidelines. It is recommended for LSIL. Yes, MIT is recommended. Now, what Manpreet brought in was very good thing. The latest thing what she brought is treatment of CIN, especially CIN1, depends upon the previous reports as well as the age of the patient. That's what they say that, okay? So these are the two criteria ACC, that is American Society of Colposcopy and Cervical Pathology, they brought in saying that you don't treat the report just now, you have to have the high risk factors. These high risk factors are previous reports. If she had a previously done, I mean, in those countries regularly they do. If the previous reports are supposed to be HSIL and now it is LSIL and CIN1, you may have to have it after 6 months again, you have to screen her with HPV DNA also you have to do along with that. Suppose the previous was ASCUS and now LSIL she has got. Now you have done CIN1. That patient, as you people said, you can be following that up without doing anything. So it depends upon the age of the patient, one, because as the age increases, the abnormalities will progress towards cancer is much more than at the younger age. Younger age, even CIN2 will revert back to normal in many of them, more than 50% of them. It may not happen in the aged woman. That's one factor. Other factor is the previous reports they say. These two criteria have been included in deciding the treatment for CIN1 by the American Society of Colposcopy and Cervical Pathology, what Manpreet brought in very nicely. Okay, here you follow her up. That's enough. Now, how long you will follow her up?
Sundari, my question was this.
Yes, please.
A slight deviation from the case. If this was a VIA and not a PAP, if this was a VIA and we have done the biopsy of the acetovite and we find CIN that one, then what? It was not, no PAP has been done. It's a VIA test.
Okay, see, even if it is a VIA, you will see VIA lesion where it is. It is in the near to the transformation zone, in the transformation zone. All this will tell you the sweet score. Even in VIA, acetic acid. See the type of acetovite area. It is geographical. There are sharp marks. I'm not going to talk all those things. Once you see and you think that there is possibility in that area, you would have taken the biopsy. If that comes as CIN1, enough you can follow them up.
Okay.
Okay.
So even VIA works almost as good as pap smear for if there are acetovite lesions present.
Yeah. Acetovite areas, if you can read the acetovite areas properly, you can classify them properly. Yes, it works as. That's why they say, no, the sensitivity is same for the PAP and VIA.
I wanted to bring that out because in camp settings, sometimes only VIA is.
No, but see,
Yes.
in the camps, when you're doing it, you have to give some time for it and you must see the geography of the lesions, if there are lesions. And suppose in a menopausal woman, VIA is not at all recommended because of the transformation zone being inside.
So in this case, because she is premenopausal, I'm
No,
talking about-
subjective. It is VIA. Why it is not recommended now, as a WHO Bhagyalakshmi was telling, only HPV DNA is, it is subjective. For me, VINA, because I've been doing it, it may look like abnormal. For you, it may not look. Even metaplastic epithelium will take up acetic acid and it will be a very mild, thin VIA.
Nice point, madam.
Okay. So, yeah.
One
this
question.
is all to be differentiated. You should be able to differentiate it. That's why it becomes subjective.
Subjective.
If you are
Ma'am,
very
can
good
I
at seeing everything,
case, otherwise we'll not be able to discuss all the
no,
cases.
shall we?
Ma'am, one question.
Madam, you said how many years you should follow? Probably 2 years, yearly,
Which one?
yearly, twice.
Yeah,
You had
no,
asked that question.
If CIN is persisting for more than 2 years,
2 years, then
you have
only.
to go. Or CIN, see one thing, the CIN one, you think that the patient cannot come back regularly for a follow-up, do a cryo. Ablation you can do, cryo or thermal, whichever is available. Okay.
Non-compliant.
If she is able to come regularly and you think that she is complacent with that, you can follow her up for 2 years. If it is persisting, CIN1 for 2 years, then you have to do better than ablation. You do a excision treatment.
If this was the only,
So
Ma'am, one
that
last
is the
question,
basic,
please.
Sundari, can I ask you? So that is the basic for that see and treat, right?
See and treat is when screen and treat. That is screen and treat is you are doing
Have a
putting an acetic acid in a camps. You see acetovite, you do the cryo or a thermal is screen and treat.
Same sitting.
Now there is one more thing called see and treat. That one, because of the confusion, now they added one more word for that: see, triage, and treat. That means you see colposcopically, take a biopsy, and then treat accordingly. At the same junction, you would have taken the biopsy and then you can do off the leap also. Or leap you can do, it will come as a biopsy also. Or if you want to do a cryo or a thermal ablation, take a biopsy and do it. That is see, triage, and treat.
Okay.
Screen and treat is what we are going to
One
do.
question may I ask?
Madam, that again will take, it's like a two-step procedure, Alva, madam.
No, in the same setting you do. Teja, you take the biopsy to prove it. Colposcopy you have done. You can see the lesion.
Report,
Take a biopsy of it. Take a biopsy of it, and at the same sitting, you do either a leap. If you are doing a leap,
you don't wait for the HPV report, you're saying.
No, if you are doing a leap, you don't wait for the HPV report and you leap off that. Or you want to take a small biopsy, do it. And if you want to do cryo, you think that the acetovite maybe, as she was telling,
exactly.
5 to 7. Then 0 to 4, you can just do off a cryo or thermal. That is
You may
0
not
to
be,
4.
Sundari, you may not be able to do colposcopy in that setup. So we can take a biopsy from acetovite area and treat it. Do the cryo.
One more thing, why we do colposcopy is whether the lesion is eligible for ablation, you have to see. Suppose the transformation zone is type 2, Sheila. It is extending inside the canal. They are not suitable for ablative therapies. You have to go for excision therapy. For that sake, you do colposcopy and decide whether you are going to do ablative therapy or an excisional therapy.
Okay.
Because follow-up, it will become difficult if you do ablative.
Yeah. Especially cryo. But thermal is, they say it is better, much better. You can follow up. But cryo, you just damage everything. No transformation zone.
Yes, you cannot follow up the
That will be
patients.
very bad. Okay. It's a time up. Shall we stop here or we have to go through the
Next,
case?
madam. 2 more cases we can do.
Okay. Fourth one.
Quickly
Yeah.
we'll finish.
45-year-old, pap smear is HSIL, colposcopy biopsy CIN1. How do you manage her?
CIN1.
It is HSIL and it comes as CIN1. There is a discrepancy between pap smear report and colposcopy
Yes, that's
biopsy.
what. There is a definite discrepancy between the pap smear and colposcopy biopsy.
Yes.
But I think she needs treatment, madam, in the form of maybe a diagnostic one or an excisional leap can be done for her because she's 45.
Yes.
And it is
Yes, next.
CIN1, na? So
Yeah.
something has to be done, but not diagnostic, I think, at least ablative, or you can do co-testing.
Yes.
So that is for follow-up, madam. What we do, co-testing HPV.
Yeah, after 1 year, after 1 year.
Yes, Garima. Garima has raised her hand. You're there, Garima?
Ma'am,
Yeah,
I would
please.
counsel this patient for going ahead with a leap biopsy, leap excision, and then send it for a further this thing, or maybe go for a thermal ablation.
Okay. Shubha? Shubha is there?
See, depending on where the this thing has been done, maybe I would review the slides or just follow her up after 1 year and see whether there are any changes, or maybe you can call a little earlier at 6 months.
Because it is
We have to repeat,
HSIL,
I think.
we need
Madam,
to do
we have to
ECC
repeat
also.
repeat, I think, because there is a discrepancy between the pap
Yeah,
smear and
that's
the
what I would like to repeat it, review the slides or repeat the biopsy, whatever.
ECC also to be done.
Manpreet, yes, ma. You have raised your hand. Is there? Manpreet? Hello, Manpreet, you have raised your hand. You want to say something?
I'm sorry, madam. Madam, at 12, I will like to call her up at 12 months and do a co-testing with HPV. If HPV this time is positive, then I'll be going in for a ECC or a diagnostic procedure in this case. In case she is negative or she persists with, if she's HPV negative, then I again call her for follow-up after 12.
Okay.
Or she comes to LSIL.
Okay.
If HSIL persists, then I have to go for diagnostic.
Yeah, Shubha said she will get the smear repeated. I mean, reread by someone else. That exactly I do when there is a HSIL plus CIN1. There is a discrepancy. Either you do that and confirm which one is right. Okay. Number two, what you
Also,
can
see
do?
her previous smears, if at all she has done,
Yes.
routinely.
Usually
Shubha
I do
always tells about previous things. That's very correct, Shubha.
Yeah, that also history you take and you see her file whether she had pap smear done before. All that I'll do. Beyond that, suppose she didn't have any pap smear before, it's the first time she's coming, okay? And in your own lab only it is done, the pathology lab. Then what you could do is you do the HPV DNA testing. That adds to the severity of the disease. Suppose she is HPV DNA positive, that means the CINA closely you may have to monitor. After 6 months again, you may have to do a PAP and see for her. If it is negative HPV DNA, as all of you said, after 1 year, we can do again a repeat PAP and colposcopy and then confirm the diagnosis. Okay, shall we agree on that?
Yes, ma'am.
Yes, ma'am.
Okay, then one more thing we have. Yes. Yeah, pap smear is HSIL and CIN2 now. Colposcopy is CIN2 in a 50-year-old lady. She is not menopausal yet.
So definitely she needs
something. I know.
Yeah, you do a leap or LEDs, whatever, and then depending on the histopathology, go further and treat her.
She
or
is
follow her up.
very anxious. She says, do of hysterectomy. I may get a cancer, she says. Okay. HSIL and CIN2, they are correlating.
You can do a cone, no, madam, in this patient. Anyway,
Yeah,
she's
cone
50.
biopsy.
Cone.
She's 50.
Diagnostic
So we can do a cone biopsy in this patient.
Okay.
So that the entire.
Anybody else has anything else for her?
If she has any other problems, like say menorrhagia or anything else, then I would not hesitate to do a TAH for her.
A coincidental problem.
She doesn't have anything else. She doesn't have routine pap smear has come. Routine pap smear, it has come like this. Anybody has anything else than what they said? Yes, they are right.
Yeah, hysterectomy would not be justifiable just for a CIN2.
Yes, exactly.
But I have to
No, she said that if she has any other gynecological problem.
Yeah, then only, not otherwise.
Yes.
Along with that.
Otherwise,
see and treat.
Excision and diagnostic excisional.
See, you can do, there was one case like this. In Australia, the lady was there. One of the consultants from Mangalore was asking me this. Persistently, it is like this. This is the case where you could do P16 and Ki67.
Oh.
You do it and you can confirm it saying that, yes, it is not pro-malignant or it is pro-malignant. Once you decide that, If it is not, they are negative, P16 and K67 is negative, then you can say that you come back for a follow-up after maybe 6 months or 1 year. 1 year even, that is enough for us. Okay. And here you can do even Hpv DNA because it's CIN2. Hpv DNA you do, and Hpv DNA is positive. Then you do the P16 and Ki67. Then you will confirmatively tell her, yes, this is going to become malignant or this is not going to become malignant. We'll wait for some time, repeat after 1 year and see whether it would have regressed or it will not progress when you know that it is biomarkers are negative. So that also we can do.
Sundari,
Suppose
if it is
not there.
If it is HPV not associated,
Not
then
HPV.
Amma, it is only 7% to 11% are HPV not associated, is it not? Even then you can do the biomarker. Biomarker you can do.
And you have a period of at least another 4 to 5 years before she can, progress.
Madam, what if the Syntec Plus kit is not available? And if this is the report?
Yeah, if it is not, that's what I'm trying to say, that if the facilities are not available for us, please don't go for hysterectomy, but you can do the treatment like this
Can
one.
we do a cone, madam?
You
Cone
can do for
biopsy in this
CIN2. When you are doing the cryoablation, you have to do a freeze thaw twice. We have to do 3 minutes of freezing, 5 minutes of thawing, 3 minutes again of freezing and thawing you do. That will give you the depth, correct depth of 7 millimeters, 5 to 7 millimeters it will give you. Otherwise, if thermal ablators are there, we can do thermal ablation at one setting of 20 seconds, it will take off. Then follow them up with HPV DNA test of cure with the pap smear. That
Madam, why not cone biopsy, madam?
Why it is too much, for the CIN2?
So you said patient is very anxious.
HSIL, no, madam.
Want some
see, we are not going to read HSIL as a thing. Pap smear is HSIL. In HSIL, you have CIN and dysplasia of 2 and 3. If you take it, HSIL, both are there. It could be 2. And biopsy is the confirmation always. For us, the biopsy is confirmation. So you can do 2. I mean, see, if anything can be done on anybody 50 years, why can't I do cone? Suppose while you are doing a cone, she bleeds.
Because here we are not thinking about adverse obstetric outcome, no?
Yeah, she's already.
No. I'm telling you, see, cones, when we were doing a cold knife cones, we had in our own institute, she bled so much that we had to resort to hysterectomy. But now with the leap, yes, if you do leap, yes, fine. But for the CIN, what is practically to be done is that because 50% of them will revert back. I had one of our sonologists, a very popular sonologist of Bangalore City's wife only. I had CIN2. Somebody said hysterectomy. I said no. Followed up for 10 years, nothing has happened. Now she doesn't even come to me. So CIN2 we needn't have.
So leap is the ideal.
Leap can be done. Leap can be done. Okay, that's I think we have. This is the other one. Yeah, this is the last one we have. Abnormal cells favoring neoplasia, colposcopy done, menopausal picture, transformation zone is migrated up. What next for her? 53-year-old. This is the last one. I think half an hour we are exceeding the time. Okay, this is the last one. Anyway, I'm enjoying. All of them are very actively participating and giving a nice answer. Yes, who takes? Yes, Shubha.
Madam,
First thing I would like to do is do one imaging for her. Because there are atypical glandular cells favoring neoplasia. So I don't know whether there's anything in the cervix or whether it is anything in the endometrium. Simultaneously, I can evaluate the ovaries and look for anything else. So if anything is positive, then definitely appropriately she needs an ECC and an endometrial biopsy too. So
no, Shubha. One thing. Suppose there is a dysplasia or adenocarcinoma in situ in cervical canal. Do you think that you will be able to see in your imaging? See, patient has come to you with this report. First thing,
very unlikely.
First, you would like to do whether
colposcopy only. Colposcopy with easy.
Pap smear reports we never treat, we never evaluate, except that confirming the diagnosis evaluation. Is it not, Shubha?
But transformation zone is migrated up.
Endometrial biopsy, endocervical keratosis.
Yeah, no, why I want to do the imaging primarily is once I do anything, I have to wait for a week again to do the imaging because the endometrial thickness is not going to be reflected properly. So rather than rushing, I'll get one transvaginal or whatever
Yeah,
scan
good
done.
scan.
So I know the endometrium. I know that it is not going to show anything in the endocervical canal unless there's a growth there. And also look at the ovaries and the tubes or whatever is seen. And then I go ahead, yeah, endometrium. If the endometrium is very thick, then I'm going to combine my ECC along with the endometrial biopsy. But if the endometrium is very thin, then I may not even go ahead and do endometrial biopsy. But of course, I have to evaluate, I have to see the transformation zone, and I have to do an ECC. So I might put her on some estrogen and call her back and do whatever is necessary.
Okay, anybody else?
Yes, madam, ECC definitely in this case.
Yeah.
And then she's 53 because you said sometimes when transformation zone migrates, maybe some form of estrogen treatment, and call her back and
why do you want that estrogen treatment and follow back? This is glandular abnormality.
This is
glandular. It is definitely higher. No,
glandular abnormalities are either in the cervical canal, in the endometrium, fallopian tube, or even sometimes ovarian, as Shubha was telling. Okay, the glandular abnormalities are only that, where you don't need to give an estrogen therapy here because you have to. Are they favoring the neoplasia? It is so somewhere it is there, either in the endocervical canal or endometrial. It is there. So what I do usually when it comes is recently
everything is negative. Everything is negative. Endometrial histopathology normal, screening normal, endocervical, everything comes as normal. Still, we need to do some diagnostic procedure, isn't it, madam?
Yes, you can do. If it comes normal, you can still do a cone. In this case, you have to do cone. Okay, deep cone you can do. But what I do before that, as Shubha was telling in the previous case, I'll ask the slide to be read by somebody else. Because when there is a AGCFN, definitely there must be pathology and everything has come normal. Then I suspect the pap smear because to give the answer to the patient. Patient is so terrified, she'll go and get a hysterectomy done unnecessarily, no? So,
madam,
would you advocate?
I have a doubt, madam.
Would you advocate a hysteroscopy in this case?
It can be done by endocervical canal and this endometrial. Yes, if you see, you have done simple things. You have done ECC and pipple sampling. If that comes negative and your scan, as you said, ovaries and tubes are okay, then probably yes, you can do hysteroscopy to see whether there are any isolated lesions in the
small polyps.
Endometrium. Don't you think it'll disseminate the cells?
No, after initial ECC and pipple, madam is telling.
After first initially you have to do ECC and pipple, and then if it comes negative, that is one of the indications for hysteroscopy, no Teja?
No, the negative, but if you are not very sure.
That's what Shubha said. If it is negative, then you have to do hysteroscopy and then see the endometrial cavity, whether there is any focal lesion, you have to biopsy. See and biopsy, you have to do that.
Madam, one thing I didn't understand, madam, Sundari madam.
Yes, please.
You said typical glandular cells are seen. So no need for estrogen, because here it is, the case says that transformation zone has migrated up. So for that part, to see it properly, visualize the transformation zone properly, it's not necessary.
But it is favoring neoplasia, no Teja?
No. Why do you want transformation zone to be seen now? It is not in the
just to be
zone.
To have a satisfactory.
This pathology is not in the transformation zone. It is in the gland.
That's why you're saying not necessary. That's why it's not
glandular.
necessary. Okay.
Actually, AGC, when they say, they must say whether it's a cervical cells or it's a endometrial cells. Favoring neoplasia, when they said, definitely you have to evaluate everything. We can't take it. Recently, I had one case like this. Favoring glandular atypia, they have just said that. Favoring neoplasia illa, yenu illa. Ectocervix is normal. Then I did an endocervical and pipple, both I did. I told that I counseled the patient and her husband, and then I did it. It came as adenocarcinoma in situ, luckily.
Oh.
Yeah, then I have sent them back to the consultants, whoever has referred. I have sent them back saying that it's adenocarcinoma in situ. The glandular neoplasias are difficult to diagnose by colposcopy. You know that, no? It's very difficult to diagnose by colposcopy. Glandular abnormalities.
Yeah. Very, very difficult. Yeah.
And hysteroscopy in the postmenopausal woman is not a problem because the cornual end of the tube is apparently blocked.
Yes.
So the spillage is very, very less. I mean, it's not possible for the spillage to happen unless, of course, you're using great force and higher pressures. The routine hysteroscopy should not really cause peritoneal spillage of fluid.
What? No, if it is negative,
Am I right,
Even
madam?
if it is been accepted as one of the, though not as a primary procedure when you suspect the malignancy, but still if you have such situations, it is accepted, though there is a little spill, it doesn't increase the stage of the disease. That's what they say in endometrium.
Because we always think of this part, no, when we do something
I know.
Yeah.
But it is said now for endometrial pathology, hysteroscopy is the gold standard. So we
But
don't
here-
know. Yeah.
Okay,
that's
little
right.
spill also, like Shubha said, I think we should do.
Yeah.
Okay, thanks a lot, all of you. You
Thank
really
you.
did a very lively discussion of
Very
this.
lively.
Yeah, thank you so much, Sundari. Sorry for the last 5 minutes I was not there. I'm in the kitchen doing something.
I know. Okay, that's okay.
Sorry about
They
that,
did
but I
a
heard
wonderful job. All of them did.
Yeah,
6 of
three
them did a
cases you
nice
were not there,
discussions,
Shobha.
right?
Very
No,
nice.
no,
You were not there for 3 cases.
Shobha
Thank
had
you.
called me to tell me like to take over, but my internet connection is a little
So I
unstable.
told Jyoti actually.
Yeah,
No,
she
but
told me, but that situation did not come, Shobha. Madam was
I heard
discussing
all
and
the
we were,
cases.
so
We
we
were
did all
keeping
tell
ourselves,
only.
busy by discussing.
Didn't want to make it conspicuous
I
that we
heard-
are not there.
I heard all the cases and it was an excellent message, Dr. Sundari, that sometimes, because traditionally gynecologists feel that if there is no postmenopausal bleeding, endometrial evaluation may not be needed. But this is one indicator where earliest diagnosis can be made of endometrial cancer. So wonderfully given message, and all the
Ma'am,
panelists.
I have a question.
It was like music, you are the orchestra player and everybody is.
Oh, no, they did the job. Yeah, I didn't do
Everybody
anything.
singing.
All of them did the job.
I think
They did
Manpreet
the
wants to
wonderful
ask
job.
something. Manpreet?
Yes,
Yeah.
ma'am, I have a question, ma'am.
Yes, ma'am.
Supposing now we generally stop screening by PAP at 65 years of age. Now, in between her screening, if, as we said, she has at some stage of time, she got an ASCUS or she got a CIN1. Now, how long do we continue screening in this lady, even if there were 2 negative PAPs and an HPV negative?
No, that time you at 65, you can stop. See, that was, they say up to 65. Prior
Provided.
to that, consider
Provided.
3 times. It is negative.
Negative.
Then you stop at 65.
Yeah.
Okay, there is no
Ma'am,
doubt.
somewhere in John Hopkins manual, I read that if there is an abnormal PAP, you continue for 20 years after the abnormal PAP.
If there is abnormalities there at 60 years, you have done abnormalities there, next 25 years, you have to be screening them.
Okay. Okay.
And then one thing I just wanted to say, one message is whenever a hysterectomy is done for any other reason, please evaluate the cervix. Because recently I had a patient, okay, hysterectomy was done 10 years back for her. For what reason, I don't know. I don't have the reports at all with the patient. She comes with 3 months of white discharge. She has not told anyone in the house, and late after that, some daughter she told that she brought. The whole vagina was young. She is 60 years. Whole vagina is involved. It's a wart carcinoma. Whole vagina is involved. Very unfortunate squamous cell carcinoma. So I think we have to do, even if it is CIN1, when the hysterectomy is done, cervical report, they have to be next 20 years. They have to be, wall smears have to be taken, and Hpv Dna has to be done for them. So that this vaginal recurrence is very difficult to treat. They say apex, you can do excision. Again, it may recur. Then you give the radiotherapy. The whole vagina will shrink like this, and she will have a lot of problem. After that, we can't even put a tip of finger into the vagina. How much problems we see with that? So simple thing is just do a proper cervical evaluation before taking any patient for a hysterectomy. Whether you're doing lap hysterectomy, whether you're doing vaginal, whether you're doing abdominal, please evaluate the cervix so that half of the problem we will be solving. If suppose it is here, and after that, please see the histopathology report. We see only the
I think all specimens,
histopathology.
madam,
We
whether
don't go
for-
down in the report and see what was in cervix. If there is CIN in the cervix, please keep them under close surveillance. This is the 4th case I'm seeing vaginal vault recurrence after a hysterectomy for a benign, supposed to be benign lesion.
Not only that,
I
if it
think,
is
madam, all the
CIN3 on the
pathologists,
specimen,
they
if it is
do report.
CIN3 on the specimen, refer to an oncologist or a radiation oncologist. Sometimes they give a vaginal boost if it is CIN3.
No, CIN3 should not be given. Shubha,
No,
if
because-
you have a CIN3, you would have done the cone and see that there is no micro invasion. If there is no micro invasion,
No, I'm saying this is a hysterectomy which you have done and you discover a CIN3 on the specimen.
Specimen you're talking about.
on the specimen.
Yeah, on the specimen. Yeah, because a PAP, sometimes people just do a PAP smear and do a hysterectomy. They wouldn't have evaluated that completely. So if it is CIN3, then sometimes I have seen they give a vaginal boost.
No, that should not be. That should not be done. CIN3 follow up with HPV and the pap smear of the vagina, because CIN3, even if you talk it is in situ. And when they do the histopathology, they would have seen whether there is an invasion or not. If there is no invasion, they have given a CIN3. Radiotherapy is really an extra treatment for it. It is not acceptable treatment, Shubha.
Yeah, no, I agree, madam, that it should not be given and she should be on follow-up.
Follow-up
It is not a
Yes.
joke to give a radiotherapy for the patient.
But this I'm saying about 20 years back, we had one patient and she turned out to be CIN3. In fact, she had undergone the curettage, everything, even before we did a cervical biopsy also was done. But then the specimen showed CIN3. And then when we referred, this was almost 22 years back, her name also I remember, Ilayarasi. They gave her a vaginal boost. And then she has been following up for I think I saw her maybe just before Corona. We've been doing smears, everything is normal. And surprisingly, I was thinking a vagina is going to be bad and shrunk and all. It is a normal, looks like a normal vagina for her. It's no problem at all. She was a relatively younger patient, 45
They would
years.
have given 1 or 2 this ones. Okay. Fractions they have given.
Yeah,
But
only
I
brachytherapy,
know.
only vaginal boost has been given, only brachytherapy.
Brachytherapy they have given for
Yes,
CIN3. No, please don't say that. I don't
Madam,
know.
I think what we should learn is all the specimens, for whatever reasons we have done hysterectomy, the others, we should make sure whether the cervix is reported properly.
Exactly.
If not, we'll have to get back to the pathologist and ask them to review and give the report, I think.
Yeah, if you have a doubt, you discuss with pathologist.
See, basically
Every time
do
I
a
have a doubt,
speculum.
I discuss, I ring up and then I bother them to tell me
Yes.
and again look again. Even day before I had done that with the pathologist. Every time I do that with the pathologist.
But in our hospitals,
pathologist.
madam, always the reports are given properly. The
Yes.
fallopian tube, the myometry, everything is given clear, cervix. So I don't know, maybe in places where they don't give properly, we need to be a little
Anyway,
careful.
for CIN3, we don't need to do except that
Jyoti
we
wants to
ex-
say something.
Even
Jyoti.
for CIN3 now, they don't even in a youngsters and like 45, 50 years, they don't even recommend hysterectomy. Now they say it's only the large loop excision of the transformation zone and follow up.
But that all depends on the compliance of the patient.
Yeah, compliance,
follow-up, everything.
definitely.
Yeah.
See, I tell you,
Yeah.
my village patients, the moment it comes, I tell them they come for the colposcopy biopsy also, they've gone and got the hysterectomy done last week.
Yeah.
What do you do?
Many of them,
But
not even village.
I say for the rural women, simple hysterectomy is best.
Yes.
Because they
Sometimes,
don't come back.
it is very difficult to convince them not to do a hysterectomy.
Yes.
If you
Especially
don't do
if
it, they will go.
Yeah,
Madam,
they
if
will
you don't do, they'll go to
someone.
another gynecologist and get it done. That's
Not
all.
gynecologist, they will go to a general surgeon and get hysterectomy done.
At
least
least,
I
most
think
important
I
is
think it's the time to conclude now.
yeah.
Yeah.
Sundari,
Yeah.
I just want to say something.
Yeah.
Most important is to convince all gynecologists to do a speculum exam, which quite a few are not doing at all.
Definitely.
Unless you
I
do a
agree.
speculum and you do a pap smear, ideally I do LBC, but at least a pap smear before you think of doing a hysterectomy for
That's what
any.
madam mentioned, Sundari madam.
all
But,
See the cervix first.
Jyotika,
whatever.
see, your patients are affordable patients.
Yeah,
Now
they
you
are.
can switch over to HPV DNA for a screening, because I tell you, we used to say it's not cost effective. It is very cost effective because you do only twice in the lifetime.
Exactly.
Okay, please do it of all your
We're doing
patients.
it now.
All your patients are affordable patients. Switch over to HPV DNA. I'm trying to get in.
I'm doing that.
35 and
I'm doing
45,
only
madam.
HPV DNA.
And then 35 and 45.
Yeah, beyond
Right now-
30 years, HPV DNA.
35 and 45.
Right
I
now
think.
you have in St. John's 2,800 rupees they are doing. You can contact Premlata and she can help us. I'm trying to get the same thing in Kanwa to do a reasonable rate HPV DNA testing. But one thing is you have to see which test you are doing. Okay.
Previously, it was only 1,500 by Ranbaxy.
No, but the tests which are approved by the government FDA are only to be used now. There are only few tests are approved. Not every test, please don't, because false reports we will get. And it's very dangerous to get those reports if that a report is false. Right now it is approved is Zine Export, Cobas and Hybrid 2. These are the 3 tests which are approved for DNA. Of course, RNA Optima is there, but we are not doing RNA. DNA only we are doing. For the DNA, these are the 3 tests we have approved. We can do. They have got a Zine Export in St. John's. Probably I'm trying to.
2,800, is it?
2,800, I believe.
Yeah,
there.
that's it. It's not very expensive because you're not doing so often.
I think we will take one question by Mohini and then we'll conclude.
She's muted. She's trying to talk.
Mohini, unmute yourself.
Mohini, unmute yourself.
Unmute Mohini.
Okay.
Mohini. Huh.
Yeah.
I have unmuted.
Yeah.
So you joined very late. Sundari, I just have one thing for you. You were just telling us about a case that hysterectomy was done somewhere about 10 years ago or something for a benign condition. And you realized there was a vaginal recurrence when you saw her and whatever, biopsied her or whatever. Now, either the histopathology report of that hysterectomy specimen was wrong, or this vaginal occurrence is a primary lesion. It is probably may not even be related to her cervical issue at all. So how come a patient who has been
Mohini, at 60 years, vaginal carcinomas are very, very rare. They form only about 2 to 3% of all gynecological cancer, number one. Vaginal cancer occur only after 70 years. It doesn't occur before. This lady was, I told you, this lady was about 58 or 59 years old. Okay. So, under hysterectomy done, the cervix, whether it was evaluated, I don't know. I don't have all those reports.
Yeah, that is what I'm saying. Either that thing was wrong to begin with. Okay. So it is difficult for us to interpret that this vaginal occurrence is a cervical, is secondary to a cervical cancer. So we don't know that. And what was the histopathology of that vaginal recurrence? Was it, what sort of a cancer was it?
It is squamous cell carcinoma. Most common is squamous cell carcinoma. No, it is squamous cell carcinoma.
What you're talking about? No, we are talking from the.
Yeah, it was squamous cell carcinoma only.
And relate, probably that histopathology done at that time was probably there was a mistake somewhere. That's what I
Or
feel.
sometimes the specimen is not sent only for HP.
Exactly.
Or, you know,
Many a time.
they would have
Many
done
a
for
time they don't
fibroid
send.
uterus and not sent it for HP.
Yeah, it is fibroid. No, why should we send it?
Yeah.
It is fibroid. Openly no.
Many
Why
people do
another
that.
expenditure for the patient type? Why
Yes,
another
they are trying
expenditure
to
for the
cost
patient?
cut.
One lady said that. Why another
Yes.
expenditure for patients? It's a fibroid. I know I've seen the fibroids.
No, we have seen that happen many times, especially in the rural areas. To
Yes.
save that 200, 300 rupees or something, they just throw the specimen in the bucket.
Yes,
It's not at all sent for
It
HP.
happens. See, all of
Madam,
us
we
must
have
change
in our
our
HBS
approach.
hospital.
All of us must change. All of us change a lot to just get this 2030 elimination of cervical cancer. In Lancet, it is expected that we are going to do only in 2070. I don't be alive and I will not have a rebirth also by then. But 2070, it is expected if we start now. All of us start now working on that. Imagine. That is the problem, magnitude of the problem we have in India. So all of us must change our attitudes and really have to do something to the society. Yes, ma'am. Manpreet, you have something to say.
Ma'am, one suggestion that I have is to increase, because our PAP testings are decimal rates we have. Madam, let every medical college in the first year give one student at least a dissertation on cervical screening. So that every year, supposing it's 2022. So what is the incidence of cervical dysplasia or something in Bijapur in 2022? 23, another person comes in. At least let them do 1,000, 1,200 cases in the 2 years that they have. I think if this is carried over all over India, I think our rates are going to increase a lot.
Very good. Very good suggestion.
One thing I want to tell you, in a medical
And all that
colleges,
time, believe
no,
when I'm Ramaya, wherever I guided the students, every time it used to be on something on cancer cervix. Either in the community or in the hospital, we have done.
RGHS doesn't want repetition in the last 5 years. You have to change
Yeah, but
little here and
madam,
there.
if Foxy takes
Full
forward this
RGHS.
suggestion, madam,
No,
if
one
Foxy
thing
takes forward this seat.
One thing
Now
I
you can
want to
repeat,
say,
Pratik.
just
That
see,
clause is not there.
just to make it happen, we have to have a separate unit for the obstetric OPD and a separate unit for the gynec OPD.
Yes.
Because the
Yes, we have
maximum
that.
importance is given to the obstetric cases. The gynec cases are neglected because the obstetric, the consultants are so busy clearing the obstetric crowd, which is more than 200. And gynec cases get neglected. Dr. Jyoti is here. Usmania Medical College, Hyderabad has that, if unit 1 is having obstetric OPD, unit 2 is having gynec OPD.
Government
What
maternity
happens
hospital.
is the patients are not neglected. They are seeing only gynec patients on that day, and they thoroughly screen. They can do pap smears, and then I think that culture has to come to bigger institutions, the private as well as the medical colleges.
Sheila,
Because
you
they
started
are less
KCG,
serious,
no?
no?
So many patients we can get
But
in
Martha's
KCG.
has that, right? Ops and gynae separate.
We
Martha's
had, but unfortunately, some administrator thought, how can you have separate antenatal and gynae OPD? I mean, gynae OPD. So he said you can't send away a pregnant patient who comes on other days. He didn't understand. Then
ma'am.
now all
Ma'am,
the
we
OPDs are clubbed together.
Madam, in NMC requirements, the latest NMC requirements, you have to have gynec units as well as obstetric units. Now, for 250 seats, we should be having 3 OB and 2 gynec. So every day we have 1 OB and 1 gynec unit which is working separately. And that is an NMC requirement.
That is being fulfilled also in all medical colleges. So Sheila, I wanted one suggestion specifically for Bangalore Menopause Society. I felt that let us start a registry for cancer service, and each one of us feed in. Let us make a beginning. How many PAPs we are doing and the results, each one of us, and we will request Dr. Sundari to take the lead on that to solve queries. For example, like today's cases, suppose any of us come across difficult cases, let us look towards a team building for solutions. And
towards that, Shobha, my suggestion is let us make some formats and give some to each institution which is interested. I mean, all should be interested. So let us have a common format so that everyone will fill in the details properly, and then we should be able to evaluate that at some time.
I think we should have a submission online. Because again, collection and all that, at least at the end of 1 week, they should just submit it. Okay. So we will think about it. Dr.
Apart
Sundari,
from that,
Yes.
even this
Monthly ones,
camps
like,
also very
what
important.
we submit to the government about our scanned this one's reports. Monthly ones, if all the gynecologists submit also, we can make a pool of 10. Yes, we can have. It's a wonderful idea to have statistics.
We'll focus on the members of BMS first because we can't make it very wide.
Yes.
And we'll create a Google form, Sundari Alva.
Yeah. Google Forms create one
we will create a Google form.
Shobha,
But
it's a very good idea.
Yeah.
Shobha, it's a very good idea.
So only after the entire evaluation has been done as per protocol, and we submit. And whatever difficulties which come can be discussed. Yes, Jyotika.
Yeah, I was telling you that IMS has come out with a registry. It's called a midlife Indian Menopause Midlife Registry. It was inaugurated only today morning. And for the time being right now, there's a pilot project for 3 months. Once all of us who are in the pilot project do a good job of it and understand how to go about it, then later it will be released to all the IMS members, 4,000 and odd IMS members. So in that you have everything, all aspects of menopause will be covered, and it's extensive. So you don't really need to worry about this particular project which you are thinking about now. We all can join that and make it more meaningful.
Jyoti,
So
what she's telling is,
Jyoti, I want to tell you that will get diluted. If we are
Yes,
concentrating
exactly.
only on prevention of cancer cervix,
yes,
let us do something locally, simple.
Yes.
This is simple because that is very elaborate, Jyoti.
Very elaborate,
Life
I know.
registry is very elaborate. We ourselves, we are taking time to understand. So let us have something special and focused where we are concentrating on prevention of cervical cancer.
Our own Bangalore city, let's do here. How many
Only
cases
Bangalore,
are there?
only
How many
Bangalore.
we've
Yeah.
prevented? Then
I
we
know.
will go to the periphery of
Each
Bangalore.
one of you all is attached to one institution. You all can do a lot.
No, that's why we said we will have a protocol.
Okay,
We
fine.
will have a Google form and then we'll submit it. First, we will collect it and then we submit it. Okay, Dr. Sundari? Dr. Sundari can guide us for that. Okay?
Yeah.
I
Google
think
form
now
we can do. And see, I'll write a form, what we need to know, and I'll send it to you people. You correct it and you add, delete everything, and we'll finalize it one day, the form. That can be done.
Okay, fine. That's a very
I'll send it to
Once
you,
a month,
Shobha
collect
and
all the
Sheila
forms.
first, and Shubha. All three people I'll send it. You people say office bearers. And then if it is okay or if something add and delete and all modify, you can do it and finalize it. Then we will put it to all our members.
Suchitra is there. Suchitra is logged in, no? Suchitra?
Yeah, she
So,
is there.
ma'am, we will need to create a Google form from the protocol which Sundari sent, and we will do some trial submissions in this week and see how it goes, and then we'll make it available. Okay, Sheila?
Okay, fine. I think we should conclude now, Shobha.
Yeah, I think we should conclude this program, and it's my pleasant task to propose the vote of thanks. And everyone will agree that it is almost 3 hours very well spent. All of us have, I'm sure gained some knowledge from the stalwarts here. And it was indeed a very good program. Thanks to, of course, Dr. Sheila, the President, BMS, and Dr. Shobha, the Secretary, who have put in, this good program. And thanks to Dr. Bhagyalakshmi Naik, who really spoke passionately about, the way forward in prevention and treatment or screening for CA cervix, which is a real problem with us, though it is, I think, coming down a bit. And thanks to chairpersons, Dr. Jyotika and Dr. Sheila for all their inputs. And of course, the next session by Dr. Aarti Gupta, Club 35, was indeed, a nice thing, which I think we should all take to it quite soon and make it useful to the society in large and at large. Then, of course, the next session, thanks to Dr. Sundari Madam, it was really very nice. The cases put forth were very interesting, and I mean, day-to-day practice was what was very important. And it really, thanks to all the panelists, it was a really interactive session, and a lot of inputs and, loud thinking was what happened. And it was indeed a satisfying session. Of course, all this could not have been possible without, you delegates who are all logged in. I can see quite a few still on, and thanks to you all. And I really hope that, more and more numbers join in the next programs to come forth. And of course, all this could not have been possible without the generous help from Shield Healthcare. And Shield Connect is really a nice initiative, and I think we should all make good use of this. And of course, thanks to Suchitra, who has, helped us with all this program. Thank you. Thank you, one and all.
Thank you.
And sorry if I have missed someone. I hope I have not missed anyone.
Shobha, thanks a lot. Shobha and Sheila.
Not missed
Good initiative. It was a good initiative.
Bye-bye.
Bye.
Thank you for your kind words.
Teju,
And, once
Teja,
again,
get
thank you,
ready
ma'am.
for the next month program.
Yeah. I will.
Okay, thanks a lot.
Bye, all
Thank
of you.
you.
Good night. Thanks a
Bye.
lot.
Good night. Bye.
Thank you, Bharat, and thank you, everybody from Shield. Okay.
Thank you, ma'am. Thank you for your kind
Thank
words.
you.
Ma'am.
It was
Thank you so
very
much.
Thank you, Shield. Thank you, Shield. Thank you, Shield. Yeah.